Leah, can you see the screen with the agenda?
Yes, I can.
We're ready to start.
Okay, we'll go ahead and call this meeting to order then of the Eastern Idaho Public Health Board. We appreciate everyone's attendance. We have in the room with us, of course, our director, Jerry Rackow, as well as several members of staff, administrative directors. And we see no public here with us, but I want to first thank everyone at Eastern Idaho Public Health for just everything that they do, and particularly the effort that goes into putting these meetings together and making them available for the public. There's a lot behind the scenes, and they do that in order to accommodate everybody and to help us, and so we appreciate all their efforts. We'll begin with a roll call of our board members, and we'll go ahead and begin with Lemhi County. Commissioner Madsen, are you on?
Yes, I am here.
All right, thank you for joining us. I know that you've got double duty today, so thank you for carving out this time. Next, we'll go to Fremont County.
Mr. Vance is here.
And our physician representative.
Aaron Gardner here.
Jefferson County
Commissioner Young, present.
and Custer County,
Commissioner Butts, present.
Madison County,
Commissioner Mendenhall, present.
and Teton County.
Bill Lake, present.
And I'm Brian Reed, representing Bonneville County. We do not have Commissioner Shenton with us yet from Clark County, but we are expecting him. So we'll next go to our public comment. Our director made every effort possible to receive public comment. We have space in the room here today for any public. We also have our email portal set up, as well as a online portal that was added for public comment. We received only one comment preceding this meeting, and that was from a public member. The name on the email was E. Nichols. This person has been critical of us in the past, and we appreciate any comment. We would hope that it would be constructive and comments that could help us in our mission here. They were concerned because on the agenda, it requires masking in this facility if you are not able to social distance. And they felt like it was a little disingenuous that it's required here, but we're not requiring it at schools. Of course, it would be required here. This is a public health facility. And so every effort is made here. Schools are also welcome to require it in their buildings, but the legislature has made it clear that that is the responsibility of school boards and superintendents. Teachers can require it in their classrooms if they like. Everybody can require it as they see needed in their own facility. But it is not the role at this point of public health to require it, and we are not able to require it at schools. And so I hope that answers that question. We are certainly not being selfish or self-centered. We are asking all the public to protect themselves as much as possible, and counting on them to do it in their own way as they see needed. Is there any other comments that need to be made at this time? Okay, that was the only public comment received, and as I said, we appreciate all public comments and look forward to any suggestions or help that any of the public would have for us. We'll move on to approval of our consent agenda. In that we have, can we take care of this first?
Yeah.
Okay, I'm sorry. We do have something good happening here, but let us review our consent agenda. So it is our meetings from our November 4th public health meeting, as well as sub-grant review and approval, our financial report for 22 and the 1920 audit report. Everybody received that in their packets. Is there any questions regarding any of those or any changes that you've made in the minutes? If not, I'd entertain a motion.
Mr. Chairman, I would make a motion that we approve the consent agenda.
Okay, is there a second?
I would second that. Commissioner Butts.
Okay, any discussion? If not, all in favor, say aye.
Aye.
Anyone opposed? Okay, thank you. All right, thank you. Now we have something that wasn't on our agenda, but something that we're really grateful for. And Jerry, I'll let you explain.
Yes, thank you. I would like to welcome Mike and Emily from the Bank of Commerce here with us this morning. We have been the fortunate recipients of several contributions from the Bank of Commerce in previous years. And again, this year, they have made the decision to donate to Eastern Idaho Public Health. And so we invite them to come here and make a presentation today. I would like to ask them to say a few comments, and then Amy and Rachel, I would like to share a few comments as well. So.
Well, thank you so much for the opportunity to be here today. Yeah, I know you have a board meeting and you have a full agenda, and appreciate just a few moments to come over here and allow us to thank the work that Eastern Idaho Public Health does in the 8 counties in our area here that serve the need with your mission of prevent, promote, protect, I think is what your mantra is. And you know, we've done this for several years. These are good days when we can come over here and donate and hopefully help you further your mission. You know, I think a lot of people didn't understand, or I think it got magnified in the last couple of years with the work that all of your staff does with COVID.
Right.
You know, who had that scenario in their plan there. So I think that got magnified with the impact and what you represent and help our communities with, let alone all the other heavy lifting you do throughout our region. So on behalf of the board of directors of the Bank of Commerce and our employees and our management, you know, we're proud to present this donation for $5,000 to Eastern Idaho Public Health. Thank you very much.
So again, thank you again this
You're welcome.
year. A donation like this really allows us to look at what pieces are missing in our community, you know, what specifically to our patrons. And so the last several years, it's been phenomenal to look at what we need and put that money. And so we've done things like the homeless stand down, we were able to provide vaccines. We also have been able to put a lot of those funding into mammogram voucher program for women in need that can't afford to have their annual mammogram. And then I'm going to let Rachel identify something new this year. Indeed, it's been there for a long time, so I'm going to let her talk about specifically what we're going to do with that. About $5,000 this year.
So this year we've been able to implement colposcopy procedures, which is a procedure to help identify, prevent cervical cancer. And so diagnostic procedures can be very expensive, especially for uninsured individuals. So this will directly help individuals who are not insured to get the diagnostic procedure they need after an abnormal pap smear. So thank you so much.
Thank you.
Thank you.
Let me get a picture of all of you there together. Okay, great. Thank you.
Thank you very much.
Thank you. I just can't tell you how much we appreciate the support and the work that you do in our community that allows you to help support others in our community. So thank you so much.
Thank you.
Thank you, everyone.
Hey, what a generous donation. Good to do, so thank you. I think that shows the gratitude the community has for everyone here at Eastern Idaho Public Health. Okay, we'll go ahead and go next to our COVID-19 situation report. turn the time over to you.
Thank you, Mr. Chairman. I would just say that it is unfortunate that we're in the most significant surge of COVID-19 that we've experienced to date through the pandemic. I'm gonna just go ahead and let Dr. Gonzalez speak, and then James and Amy, and then we can wrap back up with any questions. Dr. Gonzalez?
Good morning. Can everybody hear me okay?
And thank you for being here.
Thank you. And for those of you I've not talked to for a little bit, Happy New Year. 2022 is going to be a good one. I'm putting it out there in the universe everywhere. So Happy New Year, everyone. Thanks for inviting me. I've had the chance to talk with my colleagues for the hospitals in our district. And so my report will be representing all of our hospitals. I won't go into detail because I know James is going to provide the information, but obviously we have a significant high positivity rate going on in all of our communities. The positive news, again, trying to be positive today, is with that high positivity rate, as we've seen across the nation, at different times, it's not converting to significant inpatient primary COVID hospitalizations. And again, I know James will have data on that. At this point in our particular health district, I would say that the COVID admissions are manageable. Now, with that, there is concerns that we've all been struggling with at different times and different ways with testing supplies as hospitals. And our major challenge that we have in our region, as well as across the nation, is about staffing. And staffing, I know you've heard us report on this throughout the pandemic, but I believe that this is probably something that healthcare is going to have a challenge with for quite a while. And the reason why I'm reporting that here is obviously right now we have every hospital has reported a lot of staff out sick with COVID. I don't have numbers, but the terms from some of the CEOs are significant impact, dramatic increase. At Madison, right now today, I know I have 10 staff members that are COVID positive, including, a physician or two. But we've had, across the nation, we've had staff who have chosen to leave healthcare because it was a challenging couple of years, and they realized they could do different roles, different responsibilities. There's just so much information going into why we're having staffing challenges, just like every industry. And there's a lot of misinformation out there on vaccine mandates or different things of why healthcare is having such a significant staffing shortage. And so please, if you ever want specific information on that, let us address those. I bring it up here because it does impact every hospital's ability to provide care for all patients. If you see sometimes hospitals on divert in our state, it at times is directly related to staffing. There are hospitals in the state and our referring hospitals in Utah that have had to shut down amount of beds that they are able to just staff. So I know at one time one of the large hospitals had reported that they decommissioned or put offline 60 beds. And this is a hospital that we all refer to. And that was all directly related to not having the staff to be able to accept patients to those beds. So again, great news on our highly acute COVID patients right now at a manageable level. I think we're going to all work really hard as a nation on staffing for healthcare. So anybody listening wanting to go into healthcare, reach out. But that's my report for today, unless you have questions.
Thank you, Dr. Gonzalez. You've been such a great partner with Eastern Idaho Public Health through all of this. And so we really appreciate how much effort you put into helping us stay informed and the work that you do up there. Are there any questions for Dr. Gonzalez? Hey, we're glad to hear that your hospital is manageable right now, and the cases are. We hope that this spike will recede quickly and will continue down the correct path. I was glad to hear an assurance from you that this year is going to be good. So thank you.
We're holding you to it.
All right. Well, thank you so much. I'll be able to stay on for 15 more minutes in case something comes up during the data. But otherwise, thank you, everyone, and have a good day today.
Great. Okay, we'll turn the time over then to our division director, James Porter, epidemiologist.
So I'll just speak briefly regarding some of the case numbers, not in the great detail. I invite any questions you have though. There's been one thing that I want to point out just right after Dr. Gonzalez did, as well as there's been a large number of questions regarding hospitalizations and why do case numbers even matter still going forward. Case numbers do matter, and they mattered quite a bit early on because we could reliably predict how many hospitalizations came from the cases, right? That's how we built our plan. It proved out to be very accurate. With the increase of the Omicron variant that is circulating, that has proven to be less reliable. If at one time will be reliable, we just don't know it in the thick of it, right? Early on, we don't know how much Omicron is contributing to hospitalization. So sadly, case numbers right in the thick of it don't mean as much to us, but they still are a helpful indicator for workforces in our community, which was a major reason why we put together the plan that is now retired, but in the first place, and why we care. We care about hospitalizations to a great deal in life and severe hospitalization, but we also care about the workforce and kids going to school and all of these other impacts to our society a great deal. So that's what we're seeing the impact right now is to those workforces. As Dr. Gonzalez mentioned, for our own workforce, maybe not seeing, we're seeing a slight increase in hospitalizations, and we'll get to that in just a moment, but level, which we're happy about, with the workforce being severely depleted. You've heard talk about this being a mild disease. I don't love to use the word mild, it's less severe. There is some cases of mild disease, but it's serious. I like to use it still impactful. People are still sick and cannot work or do not feel up to working at the level that they should. So it's still impactful to the workforce. As always, our case numbers are presented on our front page, but a lot of great detail is in the pages behind that and what we're seeing. You've heard talk maybe across the state that we're not able to accurately represent numbers. I'll go through that in just a moment. My staff have done an amazing job throughout this pandemic of putting in sometimes really long hours to make sure that we're doing our part to make, informing the public of what they can. That has become increasingly challenging over the last few weeks. We are behind in our case counts over just the last week. We're able to keep up until last week, which is, in all honesty, a great accomplishment by that staff. So, but we are behind, and I'll show you just a little bit what that will do for our numbers. Also, I'll just point out our active rate. What we used to go off of was our 10-day active, how long those individuals were considered in isolation by public health, with the decrease of 5 days in most cases, as long as individuals are feeling better and have improved symptoms. We've reduced that down to 5 days as well. So that active rate has shifted a little bit as of December 27th of the CDC again. So all the historical active rate is correct based off of a 10-day, but since December 27th, it's now a 5-day. So, Jerry, will you just go maybe to our district page 2? So, and we're gonna look at that bottom right. Let's here around, sorry. We'll zoom in here a little bit. We're sometimes seeing 3 or 4 times the amount of peak that we saw early on. Our highest peak was actually in the fall of 2020. We saw an almost very similar peak of Delta in the fall of 2021. But these are, again, case rates that we saw, and you can see that they went from a not so mild baseline there kind of in December and rose sharply. And you'll see it as we go, if you'll click weekly counts, you'll see it even more on this. This is, I think, a better way to look at it as a weekly number. We count from Sunday to Saturdays. You can see that right hand of that graph is just speeds up on an almost, sharp 90-degree angle there going upwards. That's the impact that the workforce is in our community. So we're hopeful, as some preliminary data from other countries. What also makes this challenging is this spread very rapidly across the globe, where I think due to the increased travel that was just at that time of year in the holidays, but also trying to get back to some normalcy, there was some increased travel and as well as this Omicron is contagious, period. It's very contagious and it is able to break through different protection layers that we've tried to build up over time, where we see this rise in cases. So again, we're not seeing it increase in hospitalizations as of yet. We're hopeful that continues. We're seeing this sharp peak. What's difficult to predict is how we get over this, because all countries are kind of in the same boat at the same time. At the very beginning of this pandemic, we kind of had leading indicators from other countries of what we might be able to expect, depending on their experience with that variant. Everybody's kind of going through this at the same time, or at least within weeks of each other. There is some indication that the United Kingdom and maybe some of the East Coast states are seeing a drop in cases. We're hopeful that we see a drastic drop in cases. So, but again, I think that's a hope of ours, not necessarily what I can predict with 100% reliability. As such, do you mind going to the PDF, Jerry? This to talk about case counts just in a little greater detail. The state has put some estimations together across the state. I want to contrast that at some point with ours. So you can see on this graph, the blue is what the state has recorded and presented to the public on their dashboard. They wait until we're able to do our investigations before they put it up on their dashboard. So the blue line is what public health districts across the state, and it's hard to see. You can see the last 2 weeks. This is again on a weekly, but even that last week of December, there's a little bit of orange that some districts have not been able to complete. So again, you can see that sharp increase. So an expected, I can't read that from here, that's all it is. That one that you're on there.
28,500.
Yeah, so last week, the state has received 28,000 electronic lab reports as well as case investigations from districts. Now, there could be some faxes in there as well, which escape the electronic system that districts are also putting on. So again, those are to be assessed. And I don't know if we can address, yeah.
James said, just curious, how much are these numbers impacted by the sharp increase in home testing?
Yeah, so great question. We don't recognize home testing. We don't get reports on it. If individuals call in and want information about what they should do, absolutely we try to provide education. However, they don't go into the actual reporting to the state or to as a reportable disease. There's a couple reasons for that. You can imagine we can't, if Dr. Gardner tests somebody at his practice. I know with surety that you probably did it correctly and that that person is who they say they are and that kind of things. At homes, we can't do that with any sort of certainty. So as such, we don't have that. But again, I'll take a moment right there. We're not here to just count cases. I mean, that's a kind of sometimes a helpful tool in helping to predict hospitalizations and some of those things. But what we really are here for is to help provide people education to help prevent spread, and to do those things. If that doesn't require testing, or if that requires an at-home test, by all means do that. But I think individuals know what they need to do. We plead with them to do that, and that's really a main reason we're here. We're here to help kind of understand the numbers and get that out and what we can expect, but really we're here for education. And again, a test to tell you to stay home for a few days, while good, isn't that always 100% necessary. So, and then Jerry, if you'll just scroll to the right, it's like it may be cutting it off. And I apologize for kind of dark background here on this one. It's really difficult to see. But this just, and I'll maybe bring this up a little bit later. You can see we did the same thing with our own data. We're actually caught up through the last week. You know, we always receive some reports a little bit late from providers. That's just how it is. So there's always some numbers that are changing a little bit. But where blue line is kind of where that arrow's hanging right there.
About
And
1,100,
what's that?
about 1,100 cases.
About 1,100 cases. And our orange, what we still need to get complete this week, and the staff is working hard, is up there. So again, we're going to increase this week in case numbers, not as dramatically as the previous weeks. That may indicate again that we're kind of hitting our little peak and going to drop down soon, which we're hopeful. If you're going to ask me estimation, I don't have a crystal ball, but I'm hopeful that we'll peak again this week and go down.
Well, and let me add here first, thank you to you and your staff.
Yeah.
I just looked up the last email I got from you, maybe it was over the weekend. We were behind 16,000 cases in the state, and you were 268
Yeah.
behind. So credit to you and your hardworking staff for keeping up as well as you do.
Yeah, the staff have been great throughout this. I'll say right now, the state is about 30,000, and we have about, 14% of the state's population. You'd expect maybe 4,000, and yeah, we're just right around 1,000 cases at least. So we're trying to do that as efficient as possible.
James, could you just please explain how it reflects on the daily number?
Yeah, so thank you, Jerry. So you will see our daily numbers reported maybe slightly lower than you would be expected if you look at a weekly amount. That's because we are not able necessarily to get them in all that day as they come in, but they do. We do go back and report them on the day that we receive them. So we're very cautious about that so that we can actually present as accurate as data. It may not be on that day, but in a few days, that daily count, if you hover over any of the daily incidents, you can see the actual number reported. So usually by Tuesday or Wednesday, we have a pretty good understanding of the previous week. And again, looking at this on a weekly basis, now that we've been in it for a while, is really helpful. Actually, I think presents a better understanding of what we're seeing. Don't always pay attention to maybe a 350 daily incident report. It could jump up to 600 or 700 or 800 as we saw in the last few days and weeks.
Are there questions?
James, is there a correlation or have you seen an increase in immunizations, vaccinations with the increase in cases?
Yeah, I'll let Amy speak to this more in just a minute, but I think in general, as cases rise, people are more aware and probably tend to get a few more immunizations.
Dr. Gardner?
I just wanted to add one comment to what James said. Just anecdotally, it seems like the education, the purpose of the health department to slow the spread of disease, it seems to be that water seems to be getting to the end of the row. I'm seeing more and more families who may bring a child in for testing, that child tests positive, and they say the other 3 or 4 kids at home are sick as well. We're just gonna keep them home for the next 5 days and treat them like they are. So I say that to say, I think the spike in numbers is just a fraction of what is actually occurring in the community. But I also think more and more people are going, we're sick, we're just gonna stay home, and making some correct assumptions that there's a good chance that they are positive with this variant. So I think it's working.
I've got a question for you, Dr. Gardner and James. Help me understand this, because this is so contagious and spreads so quickly, that this spread around the world quickly, and because we are seeing less serious sickness from it. Isn't there some positive in this? I mean, we are certainly getting immunity spread very quickly. And rather than just continue to piecemeal, will this possibly help us turn this into endemic?
Yeah.
You want me to take my first shot?
You take the first shot.
Yes, possibly, but what we don't understand is how long that immunity will last, right? What we saw with Omicron is, in all honesty, it doesn't care a whole lot if it's not been really recent that you had COVID, or from a natural immunity perspective, or even a vaccine fairly recently. That's why they recommended getting a booster to help protect. But we're hopeful that, yeah, as many people get it, and it's a less severe disease for many. I don't want to say for all, because again, there's can be complications. However, we want that immunity to last, and that's going to be the question that really determines whether this is a good thing or not. I'll just take a moment too, where there's been a lot of talk about pandemic versus endemic a little bit. That there's some benefit to calling something a pandemic. Very little. At this point, if this was an endemic disease, or just it's with us all the time, I would still be concerned about this many, cases of anything in our community. So whether somebody calls it a pandemic or an endemic, I don't care very much, in all honesty. It's affecting our community and our workforce. We're going to be concerned about that. Flu is endemic. If this was great, if we were seeing this many flu cases, I'd be concerned. Yeah. So.
Yeah, I completely agree with everything Jim said. Just from my experience, particularly over the last 10 days, this has been a 10-day thing, and it happened overnight. And it certainly, my sense is, my hope is the same, that this will start to see some generalized immunity. But the people I've seen turn positive have been vaccinated. Many have been vaccinated. Many had it 6 weeks ago with Thanksgiving. And so I don't know, does another one come around in 3 months or 9 months or 18 months from now and kind of do this all again? We do this for a decade? I don't know. I'm hopeful that to your point, that this will create some herd immunity of some sort. I think one benefit is, I don't know, maybe it's not a benefit. It seems that because this is so widespread, so many are turning positive, that there is kind of okay, I've got it. I've had it. You made it through. We're going to keep making it through, and we're going to move forward. Kind of a bit more of an acceptance, like the community seems to be with influenza, right? Every year we have influenza deaths. We have a vaccine available every year. It's not perfect, but it seems to help. And I think there's a little bit more of a tendency towards that we can live with this. We can still go to work. We can still, life can go on. We need to still be careful. I'm hopeful.
Thank you, Mr. Young.
Just wondering, what's making me a little nervous with this Omicron variant? Is there any unique symptoms that we can look at and say, hey, it could be Omicron? I see people going to work that, oh, I just got a cold. Well, that makes me nervous.
Yeah. Great question. I appreciate that question. I'll just say one more thing that I maybe forgot to mention. As we see such a high case rate, that does lead us to a concern overall in the world about other variants being able to kind of sneak in there. So we don't love seeing super high case rates of anything because it can kind of breed or help facilitate that other variants. Commissioner Young, to your question, we are seeing, and we have throughout, maybe not so much as individualized to each variant, but just kind of a waxing and waning of like predominant symptoms. We are seeing more headaches with this, more sore throats than we have with past variants. That congestion is still there. Fevers at times are still there. But again, whether you have a cold or COVID-19 or SARS-CoV-2, the virus that causes that, or another, or influenza potentially, or an RSV that is really harmful for young children, please stay home. I mean, don't pass it along to others. So again, if they're saying, well, it's just a cold, well, it may just be a cold for you for SARS-CoV-2 or an RSV, but it can be really detrimental to somebody else. So protect others around you, especially when you're ill. Yeah, that's what I say with 100% certainty. Stay home when you're ill.
Other questions?
I'll just put one last plug in for the dashboard. It's updated on a regular basis and it has lots of great information on what the efficacy that we're seeing with the vaccines, as well as lots of great things. And we're trying to keep that updated, 5 days a week with all the information.
And that was one question I had. I'm not sure who wants to take it. Maybe you just mentioned, I mean, are we still seeing benefits from the vaccine?
Absolutely, we are. While we are seeing more what was categorized as breakthrough cases, we are still seeing a benefit or a reduction of individuals that have received it in not getting COVID as much. We're still seeing many more unvaccinated or previously vaccinated quite a long time ago individuals, and hospitalizations for sure. The vaccine's good at providing, helping protect against severe disease and hospitalizations.
Okay, thank you.
I can expand on that a little bit too.
So we'll go to our Clinical Services Division Director, Amy Gam.
So not a lot of updates in the vaccine world. Everyone currently now 5 and older is eligible for a COVID vaccine. That includes now as well the 3rd dose for immunocompromised individuals down to 5 years of age if they've had an mRNA vaccine as well. Booster doses, a little bit of a change there. They did shorten that time span for a booster dose for the mRNA vaccine. So the Pfizer and the Moderna used to not be eligible for 6 months. Now you can have that at 5 months. And I think that was because of the variant Omicron, seeing those cases after those first 2 doses. In fact, as low as 37% efficacy, and sometimes with just that original primary series. So that booster dose, we don't have solid data yet. It's new, all that's moving through, but clearly we're seeing less cases for people that are boosted recently. On our webpage, I think we're showing about 78% of hospitalizations we're still unvaccinated. I'm sure some of that still, and James would know, some of that still could be some Delta in there, I'm not sure, but so I don't know if that's the exact percentage. But nationally, data is showing, at least with that booster dose in the last few months, much more less severe disease. But I have jump to this slide. Somebody said this in a meeting we were at the other day. Even though Omicron variant has increased ability to evade immunity from vaccination, and I would also say from prior disease as well, not just vaccination. Vaccines and boosters will lower the risk that an infection could land you in the hospital. And so that's the bottom line. And I try and tell my staff, it's a little disheartening when we've been spending the last 14 months, vaccinating everybody, to see vaccinated people come down with COVID-19. And so it just feels like to them, they had a meeting that was really emotional for some of them. I was surprised the other day. We've been doing all this work for 14 months and now we're still seeing those cases. And so I really tried to reiterate, we still are doing great work, and we don't know what the next variant is. We're still doing things, we're keeping people alive, and keeping people out of the hospital. And so we need to remember that. And we are seeing, I just went, James was asking me how many first doses I'm seeing. So we're seeing in Idaho Falls office about 40 a week the last couple of weeks, which is way higher than it had been. Everybody that we were seeing were booster doses. But clearly people are coming in for their first dose as well. So it's definitely having some impact in our community. And I'm sure it's somebody they know got very sick, or who knows what the motivation is all over there. But we're having people in there. I just did an 81-year-old yesterday come up and helped for her first dose. I'm not sure, because she's been eligible since February 1st of 2020. So, and so it's been interesting, the dynamics the last 14 months through this vaccination. And we're going to keep doing what we're doing. We're going to keep doing, and I hope our staff will understand this as well. Bounce back around now. One thing on the booster doses, outside of 12 to 17-year-olds, they can only have Pfizer because it's the only current vaccine available in the U.S. for that age group. But anybody else, regardless of what your primary series was, now you can boost with any of the vaccines. I would see the change we see most often are people that have the J&J originally are now boosted with an mRNA vaccine. But we have people that we have Moderna, getting the Pfizer, so it's kind of been all over. Some people are just staying straight across the board, but lots of flexibility there. A new term is fully vaccinated and up to date. This is new for us. So fully vaccinated means a person received their primary series. And now you're going to hear up to date means you've received all the recommended booster doses available. This basically has to do a lot of it with, believe it or not, legal terms. You know, maybe there was a requirement or a mandate that said you had to be fully vaccinated. So they have to keep that definition of what fully vaccinated is, and now you're going to see up to date. So some new communication coming out will be get vaccinated, so get fully vaccinated and then stay up to date. It'll be a new thing you're going to see. So those are two different terms. And I just kind of wanted to end with our numbers, you know, as we moved into a new year. We give a lot of vaccine in 2020, we just started just under 1,000 doses, but in 2021, some of it's still preliminary on the December numbers, but we've given over 74,000 COVID vaccine here just at our health department. Staff as well have been busy. That's what I have on vaccines, unless anybody has any additional questions.
With this, so many people getting positive, we're getting more and more questions about when can how long do I wait before I get my booster? That's been difficult information, real clarity to find CDC guidance and otherwise. What is the health department's?
Our own staff, I think James, like I asked it twice in 2 meetings last week by our own staff, and there isn't clear guidance. CDC doesn't have clear guidance. And I think the variant is part of the reason, right? We don't know how long immunity lasts, nor do they. So they don't want to give that. We used to be able to comfortably say, oh, you have 90 days, even though that guidance wasn't there. And we now know that may not be the case. So their answer really is when you're out of isolation, quarantine, any of those things, you can get it. I will anecdotally say somebody that's just recently got over COVID, they can see an exacerbation of those adverse events afterwards. And so I tell people that, and then, you know, let them make the decision. If I personally, if I had COVID, was waiting for my booster, you know, I might wait 30 to 60 days just to lessen some of those side effects, but there isn't, there really isn't a number. So I just provide them with the education and let them.
Are there other questions? I have a question that I've wondered. I guess I don't understand the true definition of a vaccine. I mean, this almost seems like it's therapeutic as it is vaccine, right? I mean, because people are getting it even though they've been vaccinated.
Right. So
You don't understand that because it's certainly therapeutic in a preventive way, right?
So in the traditional sense, yes, if I get a measles vaccine, in fact, I get 2 measles vaccines, and I'm comfortable knowing that I'm 90, whatever measles is, I don't know what, 97 point whatever % not going to get measles. And you're right, with influenza vaccine as well, though, it's been a mix and match each year, how well that flu vaccine works. But it still is preventing disease. I guess I would have to go look at the actual definition, but I still think it is preventing disease and reducing morbidity and mortality. So I still think that meets the definition. Is it different than what we think of a traditional vaccine? I would say yes. But influenza, same thing. I mean, it's the efficacy of it every year varies depending on the strains that they choose to put in there. And would you have anything to that?
Well, traditionally, I think the public thinks of vaccines as just stopping disease, and that's because of the success of vaccines in the past. I think that depends a little bit on the disease itself, as well as the herd immunity that we all kind of know. But many vaccines actually do have a component of just severe hospitalizations. Influenza vaccine is a great example. Dr. Gardner talked about that earlier. The pertussis vaccine is another one. It may not prevent you, but it's going to help prevent severe disease. So while we think of vaccines as kind of stopping it from probably our experience with like polio and some of those other ones, like a great historical example, I think traditionally it's really about preventing severe and the disease itself, but there's kind of a mix and match. So this is not unlike others, I would say. For the most part, we know that vaccines help a great deal, and maybe even stopping preventions in some diseases. But again, that depends on how contagious they are and how much herd immunity and how infectious they are. You know, so
Thank you. That really helps me because I hadn't thought about influenza and pertussis, other vaccines that are similar
yeah,
and just help us
absolutely.
avoid the serious illness. Dr. Gardner, would you have anything to add?
Yeah, I think we're in this for the long haul on the vaccines. I think there's more changes ahead for us in this vaccine, more adaptations, variations. I know some of these companies are already looking to combine them with influenza vaccines. I know of studies that reached out to participate in pediatric vaccine studies that are a little more along the lines of a traditional vaccine, not an mRNA vaccine for COVID. So I think this is going to be a part of the rest of our lives, is looking at ways to watch this and adapt to it. So
Okay, thank you.
good job, security.
Yeah, some influenza years, I mean, the percentage, depending on the strain, how well it was matched, have been as low as 30% NBC. So they're getting better at that, right? They're getting better at predicting what's going to be circulating, but we have some low coverage rates as well.
Okay, thank you. Are there other questions? All right, thank you, guys. Appreciate all your work. So we'll next go to our director's report.
Been a whirlwind of activities since we met in November. And so some things I want to just give you a quick update on, and then we'll spend the majority of our time talking about the House Bill 316 implementation efforts. So first thing is last month, not last month, January 4th, feels like last month. I still have a work sense of time these days, but January 4th, we had the bid opening for our HVAC project for this building. We did have 3 bids come in, and you can see here, this is the bid sheet that we used that particular day, ranging from $516,000 to $626,000 for the project. We did select the low bid. It met all the bid requirements and have entered into an agreement with this BNS boiler. And in fact, we will have our kickoff meeting with them next Wednesday to go over the timeline of the project and all the details. One unfortunate bit of news that we got is that it looks like the equipment is about, could be up to 6 months out. And so likely we will be into late summer or fall before this project is completed. But it's what we're dealing with now, and we're just moving forward. So it'd be another hot summer for some offices. And the next thing is the Chalice building. You recall last month at our last board meeting, we did talk a little bit about the Chalice office as we allocated some reserve funds to go into designation for replacement of that building. I recently had a conversation with the new owner of the Chalice building. It has subsequently sold, and there's a new owner. They reached out to me. We've had conversations. Just to refresh everyone's memory or to educate people that aren't aware, in 2002, we entered into a long-term lease, being able to use that building. We had helped with an arrangement to provide some funding upfront so they could actually build that building, and then that allowed us 30 years of occupancy of the building. We're actually in year 19 of the 30-year lease. However, in my conversations with the new owner, they are still not 100% settled on what they were going to do with the facility. They don't plan to have anything up and going until probably the summertime. But he did bring up to me that they may be interested in executing the early termination clause of that lease, which is a 24-month notice to us. And so I asked him if they're moving down that road, to reach out to me as soon as possible, and we'll maintain communications about it. But it just highlights the need for us to be looking at plans for what we're going to do if that's terminated early, or even at the end of the 30-year time frame. We would have the opportunity, if the owner was amenable to it, to entering into a new lease. But we may find ourselves looking for a new office space altogether. So I just wanted to bring you up to date on what we'll do there.
Is there a compensation as part of that early termination?
Yes, we would get a refund prorated in the amount that we paid up front. Okay, just a staffing update. I wanted to introduce everyone to Erin Prober. Erin, do you want to come up front, and I'll let you introduce yourself, but I want to say a day after our last board meeting, I selected Erin to serve as the new division administrator over the WIC and nutrition division to replace Angie Harwood. So I wanted everyone to meet Erin and see her face. And Erin, do you want to just share information about yourself?
Good morning. I've been with WIC for 15 years, and I've been with this health department for 8 years and working in different capacities. And so I'm excited to be the division administrator for WIC, and look forward to working with you all.
Thanks, Erin. And then just one other staffing change that I wanted to make everyone aware of. We have lots of staffing changes all the time. As a result of the COVID ongoing pandemic and funding that the state is extending to us through contract arrangements for continued immunization work, we have temporarily reassigned our nurse from our Madison County office. Her name is Esme Quintero. She agreed to take on the lead role of the COVID immunization efforts. That sub-grant through the state goes into 2024, so it's still a couple of years worth of activity that they're wanting us to do for COVID vaccinations. And so we put Esme in that lead role. She's going to do excellent. She is bilingual, which is going to be a huge benefit to us as well. And as a result of that, we're interviewed yesterday for a temporary nurse replacement to serve the Madison County office. And I don't know if that was successful.
We're hoping to offer her that position at my lunch break.
Okay, all right. So that will just be a temporary assignment, and when that sub-grant ends, then Esme will resume her duties at the Madison County office. As we're talking about staffing, it brings up another challenge that has become quite significant in the last year, but definitely the last several months. In fiscal year 20, the state, as they always do salary surveys and assessments of, salary structures and stuff like that, they had made a recommendation that 20 targeted positions, in the state's job classification, 20 different positions receive a additional 2% salary increase that year because of significant turnover and those particular positions being further below market rates than the normal state job. When that was recommended, it never got implemented right away because that was early in 2020 when the pandemic started and everything went on the freeze mode at the state level. No salary increases were implemented at all that year. But they came back in fiscal year 21 and said, okay, the state's doing great. We're going to implement that targeted pay increases. At our district, we did not bring forth a recommendation to the board to do that because we were not having the same challenges. We had pretty steady staffing in all of those. There's out of the 20 targeted positions, there's four of those jobs that we use here at Public Health. And as we assess that, we just were not having those issues, and so we chose not to bring that forward. Well, with what's happened with the labor market in the last year, we are having significant issues now with the customer service representative position. That is basically one of our entry-level positions. It's all the front people in clinical services that check in our patients. Some of our clerical assistants, we have one person in environmental health, 8 in clinical services, and then we have 10 of those positions in our WIC program. And it's the WIC program where we are struggling to refill positions. We, up until last week, we had 4 vacant positions, and we had posted job openings. We're on our 4th round now of posting that position, trying to get a qualified candidate to apply for the job. The first 2 go rounds, we didn't get any applicants. The second one, we did get a couple, and we were successful in hiring 2 individuals, but we still have 2 vacant positions for that job class. And so I would like to propose to the board that effective today, we implement that 2% increase for the customer service representative 2 job classification. We have, again, 19 individuals in that position, and we calculated here the total cost to implement that ongoing would be about $15,000 a year. That is the 2% cost on the salary plus an associated increase in benefit costs. And we do have funding in the WIC program to support that. We have funding in clinical services to support that as well. And I haven't talked to Kelly, but it's a pretty minimal impact for the environmental health division with only 1 position. So in addition to implementing that for all of our current staff, I want to set our new minimum entry salary for that position at $13.69. Currently it's $13.42, and the $13.69 would be the 2% increase on top of that. So I'm happy to answer questions that you might have.
Questions?
Is it going to be enough? I mean, everywhere in the entire health sector, I hear this, I'm experiencing it. And you make more top of that.
Yeah, and I'm gonna say the answer is no, but it'll help us for what we can do right now. And I really appreciate that because you can go to any fast food establishment, you can go to Costco, you can go to Hobby Lobby making $15, $17 an hour. And I just want to explain with the WIC position specifically, and it's true for clinical service as well, but the WIC position is a highly training intensive position. It is a full 6 months that those staff are training on requirements for the WIC program to be able to efficiently and proficiently do that job of being a customer service rep and serving our WIC participants. And when you look at that, and then you can go to Hobby Lobby and, you know, there's just no comparison. We're not even getting people that are, you know, even considering because of the salary. And I appreciate Dr. Gardner's question, because I think as we come to you this next budget year, we need to really look at what changes we need to make to be able to not only recruit, but to retain some of these positions. While we do have great benefit package and retirement, the young people primarily that are filling these positions, that's not something that they're interested in right now. They need the take-home pay to put food on the table for their families. When they get more to our age, that retirement package is much more appealing, and more weight is placed on that. But the people that we're getting to fill these jobs, they need the take-home pay right now. And so I think we're going to be facing some continuing challenges with the current labor market.
Question, Commissioner Butts?
Yes, Jim. Number one, I was just checking my emails again. I didn't receive anything as far as an agenda other than the draft human resource package. And so my question is this an action item that can be voted on today?
Yeah, it's on the agenda.
Okay, well, like I said, I didn't get a copy of the agenda, and I've been through this and through this. I can't find it. But if it is an action item, I would make the motion.
Okay, I'm ready for a motion.
I'd make the motion to accept the 2% raise as suggested by Jim.
Okay, thank you for that motion. Is there a second?
I'll second that.
Commissioner Dance, any discussion on that motion? All in favor then?
I guess if I'm seeing the numbers, you're only looking at a 20 cents an hour or so increase.
Yes.
I mean, that's hardly anything. As a minimum salary, is that, I mean, if we're gonna make this decision right now and probably address it later, but it seems like something more along 50 cents or $1 an hour makes more sense to. But
I really appreciate that, because I do think they are worth easily, you know, that. But I think we need to put that into perspective of all the other positions in our health district and come back to you as we put the budget together with a full compensation plan for all of our positions. This is something that was, you know, identified. It was very specific for these positions. Is 2% much? No, it's not.
Okay. You have some limitations, so the state salary reviews does come up, and apparently I would guess they're lagging behind the actuality out there. So how far away is that new state salary review from, how does it coincide with our budget projections and blah, blah?
That's a good
Yeah.
question. And the state, and we have relied on the state's salary assessment, their change in employee compensation report that is done every year to help inform our decisions, because we use their pay rates, we use their job classifications. So that report is out for the most recent year. And I'm still finding that state worker salaries lag behind the private sector. There has been a little movement upward, and I would say that our district is a little bit better than many other agencies because of the board's willingness to do a little bit more pay increases. Specifically last year, on average, an employee got a 6% salary increase for this current fiscal year. In the recommendation for state employees, which again, it's not going to be applicable to us anymore, but it's a 5% salary increase for next fiscal year's budget. And that includes a 3% merit-based raise, as well as a 2% increase in the salary structure. And that has happened, I want to say this is the 5th or 6th year now, that the pay structure, you know, the entry rate for every job classification has been moved upward 2%. However, only applicable for new employees coming into that job class. Any employees that were already in that class, they did not get funded that 2%. And so as a new employee could come in, they could be making more than an employee currently in the position. This year, for the state's recommendation is to fully fund that 2% increase for all the employees in the job classes. So effectively a 5% increase for employees this time of year. Those are that data, Commissioner Dance, we will be looking at as we put together our proposed compensation plan for our employees going. But I would say much of it may not demonstrate the immediate issues that we're facing with the labor market.
Is there other discussion on the motion? We do have a motion on the floor to approve the package as presented in a second. Seeing no other discussion, all in favor, say aye. Aye. Or anyone opposed? Hey, thank you. And we will be anxiously looking and expecting a way to float up the entire pay scale in our next budget.
I need to pull up because it's, unless I have it out of order here, but the next thing on the agenda is the update on House Bill 316. And sorry, I just was out of order. I want to just talk through, before we get into some of the documents that were in the packet, a status of where we are with activity relating to the change resulting from House Bill 316. So just for everyone, a refresher that last legislative session, a bill was passed that changed the funding for local public health. Previously, we could receive state general funds that came to the health districts. However, last year that was removed, and that responsibility for providing health districts with the same amount of funding was put to the counties. And so now the county is going to be responsible for a higher proportion of funding to the health districts than they were previously. And that was because of the state's desire for the counties to contribute to the cost of Medicaid expansion. So we had tried to, as we were working on that legislation, I tried to put some safeguards in there that the structure of public health would not fall apart. But unfortunately, we're finding that several things supporting public health in Idaho are seeming to fall apart. And so I wanted to give you an update on all that. The first thing is we've been working with the Division of Human Resources, and I've reported to you on this in the past. Because of the way that the wording was included in that bill, that it would be solely up to me as the director and you as the board to set salaries and manage the employees of the health district. The state their interpretation is that we no longer fall under the state's personnel rules, and therefore cannot be considered classified employees, as the majority of our employees have been for 50 years. Previously, we had only 4 employees in our health district, 5 in our health district that were unclassified, and that was me as the director serving at the pleasure of the board, and our 4 division administrators. So the classified structure is really only for state employees. And even though in the past we were not state employees, we were included in that. So because of the language change, the Division of Human Resources does not feel like we fall into that designation anymore. And it's my understanding that they will be taking forth some legislation this session to clean up 2 specific sections of code, 39401 and 39413, that mentions that we have to comply with the state's personnel or merit system. And so then those 2 changes will give the board the full authority to manage the personnel of our district. With that interpretation and that change moving forward, the health districts, all of us are now required to set up our own personnel systems. That, our policies, our leave policies, how we're going to handle employees as far as disciplinary actions and all of that. And when we get back to our proposed policies, we can talk about some of that, but many of the things that I'm proposing is going to be just very similar to what we've had in place. And we'll come back to that in a minute. What I feel is most significant to us right now has to do with the risk management and coverage. We have always been covered under the state's insurance and risk management for our property, our buildings, our automobiles, malpractice insurance for our providers, general liability insurance, and cyber security liability coverage. It is the opinion of one of the state's attorney generals that because of this change in statute, which honestly did not change the structure of public health at all, we are no longer considered under the state's umbrella, and they are telling us that we will no longer qualify to be covered under the state's risk management. For our 8 offices, it's on average cost us about $33,000 a year for insurance coverage. So we've been having conversations with ICRIM, and our district as well has had a conversation with a private insurer to just talk about what it would look like if we have to go elsewhere to get this insurance coverage. I don't have any estimates from ICRIM, and it still could be a little while before we get that. But just in very preliminary discussions with the private insurance broker, it could be $150,000 to upwards of $250,000 a year for that same coverage. And what is concerning to me is that, if you look at that at a statewide level for all the health districts, that could be well over $1 million of taxpayer funding that's going to have to go towards that insurance coverage. The district directors have had conversations with our liaisons at the governor's office as well as legislative services office to let them know of this development with risk management. And Mike Kane, who has been representing the health districts through this statute change, has been in communications with the Department of Administration to talk more about this, to see if there's not something that we can do to ensure that the health districts can stay under the risk management program. But we just do not have an answer at this point. So that's where we are today.
Why is it taking so long to get some information from ICRIM?
I'm going to ask Steve because he's the one that's been directly talking to them, providing them with all of our information on our property and our claims data.
First, the independent agents we talked to said they are also ICRIM agents. And they told me generally insurance companies won't give you a specific quote until you're 30 days out from binding. And they said they may be able to get us something a little closer than this nebulous 150 to 250,000. Because they said ICRIM, who they also sell for, plus we have to get medical liability to a separate path since ICRIM doesn't even handle medical. And we could potentially go through another separate commercial company for like car liability building insurance. But ICRIM, we've provided them what they've asked for, but apparently the renewal dates on ICRIM are also July 1 or October 1. And they may be able to get us some kind of a ballpark that they're saying to get really good estimates, probably will be in May. So I'm just thinking that for preparing the next budget iteration going into FY23, we may have kind of a scattergun shot for what that number's gonna be. So we can anticipate being substantially higher.
And I did forget to mention that even though the 316, the effective date is March 1st of 22, the change in the risk management would not occur until July 1.
Fair question.
Go ahead.
So does this also include the medical insurance for the employees?
No,
That's separate.
and in fact, that's the next thing I want to mention. We had conversations with the Office of Group Insurance back in August and confirmed with them that the health district employees are still eligible to participate in the medical, dental, and life insurance. It's likely that we will need to enter into an MOU with the Office of Group Insurance, and we are hoping, the directors are hoping to have a discussion with the representative from that office in the next week or two on one of their next calls to get that solidified. The next thing is the PERSI program, and again, we have confirmed that health district employees are still eligible to participate in PERSI, so there will be no change in that. There is what's called sick leave conversion, and currently, and for state employees, when an employee retires, if they were employed prior to July 1st of 2009, they have the ability to convert some of their sick leave balance towards insurance premiums that they would incur after retirement. There's a limit on the amount of sick leave that can be converted. It's 600 hours. But there's some question because the health districts are not specifically called out in any of the statutes that relate to sick leave conversion, whether or not that will be an ongoing benefit or option for health district employees. And so there's lots of conversations going on, but we don't have clarification on that as we sit here today. As far as the state controller's office, we've had many conversations with representatives there, and I just want everyone to know here that they have been extremely helpful throughout this process. And as I reported last meeting, not only are we changing our interaction with the state controller's office, but the entire state of Idaho is preparing to launch to a new platform for handling all of the state's financial operations, as well as payroll, employee evaluations, and it's a platform called Luma. So that will go into effect July. I get all these dates confused. Jan?
Yeah, July 1 is purchasing and finance. January 1 next year is
Will be the payroll.
human resources. So it's kind of, yeah. it's a
So-
phased in process.
So we've been working with state controller's office, and again, the way that we currently operate for all of our accounting needs, none of that is going to change. But just understanding that everything is going to change when we go to Luma, but we will still be involved in that. We have been working on for the last 2 meetings with them, working through an MOU that the health districts would sign with the state controller's office, outlining our arrangement with them. And so I feel pretty confident in the work that's being done there. We will meet with them again, I believe next week. And so we should have a finalized MOU with them in a couple of weeks. The Department of Environmental Quality, if you recall, the language in House Bill 316 took out the terminology of that state agencies could delegate responsibilities to the health department and changed it to, it could be entered into an agreement with the health districts. And so we've had a long-standing MOU with DEQ. It was actually just updated not too long ago. But then in the past, I would say 2 months since the implementation of the passing of House Bill 316, it was an easy edit to that MOU to change that language that removed the delegation terminology and replaced it with an agreement. And so that MOU has been signed with DEQ and all the health districts. And then the last thing is with the Department of Health and Welfare. Previously, the Director of Health and Welfare had the authority to delegate many responsibilities to us, having to do with communicable disease control, the food protection program, and swimming pools. And so we have been working with the Department of Health and Welfare on creating an MOU for those 3 specific programs. We're very close. We are negotiating right now on the pool piece. Included in the MOU is some reporting requirements that have not been in place before, and I will just share that there's a little bit of pushback from the health districts because it is going to create increased costs for us for the reporting requirement that they're asking, and so we're trying to negotiate on what that looks like. But that MOU, where it stands today, was included in the packet, and I just wanted to, because it is something new that we've not had in place before, I just wanted the blessing of the board before signing off on this MOU. I wanted to mention 2 things, both with the food program and the pool program. The fees for those programs are set in statute or rule, and the health districts do not have the ability to change those. They're all under the jurisdiction of the Department of Health and Welfare. And we've had conversations with the department about the need to address those fees because food fees, and many of you are familiar with this, do not cover the cost of doing the program. And so the county dollars that are help support the health district help augment the cost of doing that program. It was agreed upon that this year is not the appropriate time to try to move any legislation forward, but there's discussions about doing something to that effect next legislative session. And the food fees, I don't know if you recall, but last month when we approved the fees, there's a variety of fees. The pool fee is a flat $50 fee for us to go inspect the pool, issue a license, address any complaints that come in. It's just $50. And that is, we're hard pressed to get that to cover the cost of delivering that service. And so that's why there's just a little bit of hesitancy for us to say, okay, we'll take on more costs to provide all these data points to you. But there is commitment from the department to talk both about pool and food fees for next legislative session. So if I don't know if you've had a chance to review the MOU, or if you would like to do that now, we can certainly go through each one.
It's the desire of the board. The materials are on the website, the board materials that has all of this information. We've got time. You want to go through it a little bit? Why don't you hit the highlights for us?
Okay.
Sure.
Again, local public health has a very similar mission to State Division of Public Health. You know, our missions are both to protect the public health. There are many different statutes and responsibilities for the Department of Health and Welfare, and you've seen most significantly the communicable disease one these last 2 years, as we have had the responsibility for doing the case investigations for the communicable diseases. So in here, it just talks about that we have the authority in code to enter into MOU. We talk about just the general principles that that we will work together with the Department of Health and Welfare. You know, we do that day in and day out for every single program that we administer here at Public Health. We're in close communication with Health and Welfare if it's a sub-grant that comes through them, or in this situation of the food program where it's not a sub-grant, but it's a program that we do on their behalf. We're in close communication with not only leadership, but also the program level staff at the state. It talks about that there are rules and guidelines. We have, collaborative, I'm going to say like the food program, we have some documents in place to help the program to be consistent as much as possible throughout the state. Just that we'll share information back and forth between us and Department of Health and Welfare. That we need to follow if there's guidelines in place at the state or rules or standards that we will comply with those as we do our work. Enforcement actions, and with health and welfare, we don't see that a lot. There have been times that food establishments have been referred to the department for enforcement actions. And it just says that we will take appropriate and timely actions for that. But health and welfare also has the authority to initiate enforcement actions if necessary. We find sometimes that we do get complaints about something specific that really isn't in our jurisdiction, and we continue to refer to the appropriate jurisdiction. Just putting some of the ways that we have, functioned for 50 years into writing in this MOU. Okay. Training, we'll participate in training together as needed. Sharing information with each other. Work collaboratively in providing public information. And then as you get to the end, it is the specific protocols for those 3 specific programs: communicable disease, food protection, and the public swimming pools.
Are the other health districts using the same?
Yes, it's one MOU, all 7 districts will sign up.
Okay.
So,
Any questions on it?
Sure. Question, so the fees for the pools and the food program, are they addressed? Is everyone here that they're gonna do something about?
no,
The questions? Need a motion to approve this. To approve our director signing this.
and just a caveat that when we get to the final agreement, assuming that I'm comfortable with it, that I have their authority to sign.
Commissioner Mendenhall?
I would make that motion. Now, we are speaking of the Department of Health and Welfare.
Correct.
Make a motion to approve the MOU with the Idaho Department of Health and Welfare and give direction to the director. If she is comfortable with it, that we will follow her.
There's a second from Commissioner Young. Any discussion on the motion, Commissioner Buck?
Mr. Chairman, and Jerry, has this been reviewed by our attorney?
No, it has not. The Health and Welfare's dad, the Deputy Attorney General, was instrumental in writing it. But as we, as the directors, have reviewed it and had the conversations with them, did not feel it was necessary for review because it is all work that we've already been doing. It's just following up with the terminology in the bill that they can no longer delegate to us. It's actually that we agree to do it.
And following up on Commissioner Butt's comment, all of the directors, I mean, this is a boilerplate for all of the districts from the department.
If you can see right here on the screen,
Yeah.
all 7 health districts sign the same document along with health and welfare. So it'll be one joint document for all 8 entities.
Further discussion? Seeing none, all in favor, say aye.
Aye.
Is there anyone opposed? Okay, thank you.
Hey, how are we doing this? Do we?
Do you have one more purpose of personnel policy going to take?
Yeah.
So,
Mr. Chair, oh, go ahead, sorry.
If I could just ask, just for some clarification, we're all on this legislation. It seems it's really confusing to me, so my ignorance on this matter, but it seems like we've broke down something that existed, and now we're going back and kind of piecing it together as part of this legislation. What does the state, what do they do? Can they still direct us if there's this type of freedom? Can a health district opt to not sign on to this, and we're out of the pool business, we're out of the food business, and now if I move from District 7 and I move to District 6, that could be a very different structure, very, very different. How does that, what authority does the state then have to the health district to say, hey, we're doing this, we need you to do this?
That is
How
an
does
excellent
how does
question.
that work?
And I just want to say, it is very confusing. It's been very confusing to me as we tried to work through this, because what we thought we were getting in the bill provided us those protections that none of this stuff would happen. But that's not the case. But to your point, to your question, every health district now has the ability to say, we don't want to do that. And that would certainly be a conversation with our Board of Health going forward. If we find that, for whatever reason, that we don't have the ability to support the programs, it would just be a notification to the state that we can't do that. And what that looks like from there, I don't know. And you're right, it would be detrimental to the public health of our state. And what would help them overdo? Would they contract with someone else to do that work? I don't know what that looks like, but that certainly is a risk and a potential going forward.
What was the proponents of this legislation? What was the aim of this? Is that maybe I should?
No, that's a fine question, and I'm going to start, and I'm going to ask our commissioners to maybe chime in. As I mentioned, there was desire from the state to have the counties participate more in the extra cost of Medicaid expansion in our state. And there were some options that were being looked at that had to do with revenue sharing of the counties. And I can't speak to that because I have not worked on revenue sharing at all. The counties overall were not interested in going that route. And so this other option of the amount of funding that we're talking about could be achieved by the state not contributing that money to the health districts, and then they could put that to Medicaid expansion, and the counties then absorbing that extra cost as their contribution to Medicaid expansion. Now the thought was, and I think it will probably ring true, we don't know exactly yet, but because the counties should have less indigent costs, that they will have savings that they could then cover the extra costs to support the health districts. Unfortunately, for the majority of the counties in our health district, it will likely cost them more because their indigent costs were less than what they were contributing to the health districts. And so it was I'm going to say this is my words, the lesser of the two evils between the legislation options to make the counties more fiscally responsible for Medicaid expansion costs. That's my interpretation.
Well, and I think that summarizes it very well. And to go back, it is costing all of our counties more because we were being so responsible with our indigent dollars. Whereas there were some areas in the state that just weren't, they were headbutting with the hospitals, and so the costs were sometimes inflated, and most districts, most counties benefited from it, but ours didn't. Bonnewood County, I can speak to, it cost us considerably more. What was the reason that they went down this route? I think our director explained, but in reality, it was somewhat of a retribution against the counties because we came out in support our association for Medicaid expansion.
Mr. Chair,
Go ahead.
just one little clarification on that is that the resolution that the public health boards put out there wasn't for Medicaid expansion, it was for, I forget the term we used, but it was to cover the cost of medical expenses. But we didn't use the word Medicaid expansion. We were very careful to say that that's the only solution that we saw. We said to
Healthcare coverage, I think. is-
healthcare, whatever it was, but it was more general to say, if there's a better idea, legislators, state legislators, do it, but just another, remember the summer, they went through, they had a committee, the state legislature, who worked on this, and when they got all done, after all the other studies done, came up and said, we can't really find anything better than Medicaid expansion. I think it cost a couple of legislators their seats, but that was the bottom line, and why the legislature chose to punish the counties, particularly us, over that is, I think it was a communication issue to some extent. Now, I would like to follow up, Mr. Chair, if I may.
Go ahead.
That when we're looking at $1.9 billion in budget surplus in the state, the $70 million that we additionally had to cough up across the state could easily been handled, I think, in other places.
I don't disagree. And, you know, with that said, I'm fearful that it will hurt public health statewide. There certainly isn't going to be collaboration between districts. However, I think there can be some benefit to having a little more local control over some of the issues with public health. You know, I've got a lot of confidence in this board and in local control, and so it may even itself out. I'm hopeful that the health districts will, and this is a good step forward, that they will go together to keep some unity, so there isn't that problem, like you said, of moving between health districts. Is there other comment?
Dr. Gardner, along the lines of what you were talking about, they're finding now with that bill 316 or 319, which one? 316, the fallout and the unpredictable causes and effects that are coming from it are far-reaching. They're way beyond even the public health. They go as far as affecting property taxes and civil commitments in behavioral health and all kinds of issues. And the thing that frightens me, as the chairman said, is that there's a tug of war of the state saying, well, okay, fine, you districts are no longer a part of the state, but we need you. And so when I see things like the insurance and I see things like risk management and us coming up with human resources, I'm not sure that the legislative intent is where we are today. I don't think they started out with that intent, and it is now something we do need to manage. I read in the Idaho Code, when we talk, public health districts will have the option to continue with agreements and service agreements, including insurance arrangements with state agencies that were effective prior to January 1st, 2022. And so we have this small kingdom over here of Attorney General's office, this particular attorney who is saying, well, you don't qualify for this anymore. But the legislature, this is under legislative intent on Idaho Code. Legislative intent is, let's not do harm to the public health districts. And we're not coming together. And that's where the directors come in and legislative committees and all of that. We just have to be very vigilant that we don't lose ground for public health. We really do have to be vigilant for that. And that we need the support of the state. We do. We need the support of the state. But we can also do some things that are more effective locally. I don't understand. I don't think we're where the legislature intended for us to be. I think if they could do it again, which is hindsight, I don't think it would be like it is today.
Well, there may be some fixing this year. Is there talk with IAC or with the boards, the trustees, to get some legislation in place to fix this, particularly this insurance? I mean, in an era right now when they're so concerned about property taxes, they're putting more burden on counties. Now, it's not going to help our property that situation?
That's a great question, and we had our meeting earlier this week, Monday, and we had invited Seth Gray to be on the call so we could talk to him this, and he was not available, so we're still trying to get with him to have the same dialogue and see what we're.
Commissioner Mendenhall, could you follow up and help with that?
Yeah.
Where you're on both of those legislators?
Yes, and I know Seth tested positive for COVID, and it hit him pretty hard. We just had a meeting yesterday, and he didn't sound very good. It was Zoom, and I felt like I was being infected just over the Zoom. Yes, we will. I haven't heard much from the trustees really regarding that, following the lead of the district directors, but yeah, we need to specify to the legislators, especially where there's already legislative intent. I think we need to make sure that everybody is aware that there were correct intentions, so, yeah.
Bill?
Maybe just to help clarify with Dr. Gardner, that the Idaho Association of Counties, that's the group where all the counties are members of. They work on these kind of problems for us. And Brent is our representative for legislative action to that group. So, and this is, you may already know this, but that group is very important to us because if we have an issue, that's where we all the counties around the state can get together and hopefully sway the legislature that way.
Thank you. Any other discussion? So maybe we will take a 5-minute break or so, and then we will continue on. Anybody needs it? Back to order.
It's not far.
All right, we'll go ahead. It looks like we're gonna review the potential of proposed personnel policy.
All right. So, as I mentioned, because of the bill, we are required to put together all of our own human resource policies. And as Dr. Gardner mentioned earlier, the outcome of this bill could mean that districts are very different, and you're gonna see that starting right here with HR policies. We've had conversations among 7 health districts of how it would be really nice to have as similar policies as possible. But I can already tell you they're all over the board and really will be dependent on the local board of health's guidance. So I have put together this draft called human resource policies. And I just want to tell you that wherever we end today, it's going to take some work to then revamp our previous employee handbook, because some of this stuff related to human resources was in our employee handbook, and that will need to be updated as well. So that will be the next project, is to coalesce the 2 documents together and clean the employee handbook up to incorporate whatever the board approves for the human resources policy. So hopefully you've all had a chance to review these. I would like to go through them. I won't hit on every single thing, but hit on things that I feel like need some further dialogue. And so we'll just start through. Please feel free to ask questions at any time. And I'm just going to start right here at the very start. So one significant change that is included in these policies is the change of employees from being classified employees, which I referenced a little while ago, to being at-will employees. Again, a state classified employee is really only for state employees. However, the health districts have been required by statute to participate in the state's personnel rules. So we were incorporated there. With the change that will be occurring and us not having to comply with that anymore. As I mentioned earlier, by DHR, we're not any longer considered classified employees. In having conversations with our legal counsel about this, it is the recommendation that we move in the direction of being at will for our employees. And the difference you will see is, as a classified employee, there are many protections and a due process that was provided to employees for any type of disciplinary action. You will see in here that I have outlined a disciplinary action process, but it does not allow employees to have, appeal hearings for different reasons. It just, we're entering into an environment where every employee is at will. I will say, before I go further, that I had requested policy manuals from a couple of the counties just to review and to see where things could be similar between health districts and the counties, since we're now more similar to the counties. It is kind of a mix of what counties are doing, but I am proposing going forward that we incorporate the at-will language for our employees.
And can I add here, that would be the desire of ICRIM as well. ICRIM is encouraging the counties to proceed that way as well.
And Mr. Chairman, Jerry, with that being said, and I've got a whole bunch of information on this, because we just went over ours, we just had lawsuits. But on the last page where you have a name clearing and you're an at will, our attorney, or ICRIM's attorney says, take that out.
Okay.
And we just had ours done. I have a draft of it that I'll leave you. And I know that we don't need ours to be 35 pages or 100 pages, but you have to start somewhere, and I can appreciate that. But I do have a lot of questions.
Okay, thank you, Chair. Terry. So we just, and this is, I will say that we have taken some of the stuff that was already expectation for employees in our current handbook and just kind of incorporated it in here as well, but just outline what we expect as employees of Eastern Iowa Public Health and a governmental entity. It also indicates in here that these HR policies do not cover every single detail, that we do have a separate employee handbook that has other policies, so they will go hand in hand.
So Jerry, with that being said, if you were to go to somebody like ICRIM, they would probably recommend that you take the two of those and just create one.
That would be my intent, Paul.
So that's your ultimate goal.
Just to have one
Employee.
employee handbook that has HR policies as well as all the rest of our
That
policies
makes
that have been
sense.
established. So nothing changed with the Fair Labor Standards Act. We have followed this structure and nothing is changing with that. We do have employees that are considered non-exempt. And for our positions, the state of Idaho again does have all the job classifications, and they designate which jobs are exempt or non-exempt, and we will continue to follow that as we always have. So some examples of non-exempt employees would be our clinical customer service representatives that we just talked about a little while ago, our frontline staff. Exempt employees would be health educators, nurses, our IT professionals. And then we also have executive employees, which, as I mentioned earlier, has included myself and our 4 division administrators. The FLSA has to do with overtime. Non-exempt employees accrue overtime at time and a half. Exempt employees, they're not entitled to overtime, but we do compensate them with comp time generally, unless special approval is given at straight time. And that's how we have functioned as long as I've been a part of the health district for the last 20 years. We're not making any change to that. We would still, people would accrue comp time, but on special occasion, like right now, we have had permission. We had to get permission from the State Board of Examiners to pay out overtime. And we have for our nurses that are doing the vaccine clinics. There's no way that we could, they could build up so much comp time, they could be off for a year, and we just can't manage our operations like that. So we did get permission to pay them out, but our general rule is we allow accrual comp time.
Go ahead.
Mr. Chairman, Jerry, do we have a cap set in writing for that? Because as you just said, you start giving a whole bunch of comp time, you can lose employees for a year.
And we have that in our other employee handbook. So what I'm going to propose is that after today, whatever is approved, that I take the next month, because I'm going to propose, we have another meeting in March, which was not on our calendar because we have all these transition things that we need to continue discussing and approve. And so it would be my goal at our next meeting to bring the finalized document for review and approval by the board. Okay, so this is just terminology to refer to employees as far as their status. Full-time employees, because we are still bound by, because we're using the state's, the controller's office for all of our processing of payroll, we still have to follow the limitations. And the part-time piece also has to do with health insurance. Currently, employees, if they work 30 hours or more, are considered full-time and do receive full-time benefit coverage. And so we are keeping that same, that if you work 30 hours or more, you're considered a full-time employee. Part-time employees work at least 20 hours, but less than 30. And then we did include temporary employees in here because sometimes we do need to hire people that it's for a special project, it's for a very short duration. Right now, some examples are some of the people that we have working with the COVID response, whether it's clerical or nurses or contact tracers. This is an unusual situation because it has been a very long response, but typically if we just have a special project, that would be a temporary employee and they're not entitled to other benefits outside of those required for Social Security and workers' comp.
So Jerry, what's the maximum someone can work as a temp and not become a full-time?
And that's a question that we need to still get clarification, because right now, under the state system, and it has to do with Percy, they can, I want to say, 8 months, I can't recite off the top of my head, 1,300 hours that they can work before they have to be considered a permanent employee. And so we do have to clarify that with the state, is that going to change or is that not? And if it stays the same, then we'll still follow those rules like we always have been. Okay, job classifications, and I had mentioned this earlier, that in much of what you see in this handbook just mirrors what we've already been doing through Division of Human Resources. And so it is my proposal, at least for the time being, and this might change into the future, but that we continue to use the same job classifications that we always have, that are established through the state. All of our employees are established into one of those job classifications now, that we continue to use the pay grades that are established by DHR as well. Reclassification is really nothing new. We do that now. If an employee is in a job and whether they get additional duties or something changes that it would move them to a different job classification, we complete the paperwork. Previously, I had to go to the Division of Human Resources to get approval. We'll still follow that same process of the paperwork and justifying the need for that, but it just won't have to go through the Division of Human Resources any further, any longer. For our recruiting and hiring, for regular employees, not temporary employees, we do recruit through the state of Idaho's applicant tracking system, and we have permission to continue doing that. That's where it posts on the state's job openings, but it's under Health District 7, and the state wants to make sure that as those are done, it's very clear to the applicant that it's not a state position, that it is a position with a local public health district.
So I am trying to figure out where all of these signals were under job classifications, under recruiting and hiring. We have one portion of state government that says, no, you go on your own. Then it appears we have another part of state government that says, you know what, continue to use our services. It's okay, we'll give you authority to do that. Do we have a power struggle going on somewhere with some departments and some not? I mean, I don't want to distract from HR, but if someone is giving us permission and authorities to utilize state services, who's drawing the lines in all of that? How do you keep track of who's going to tell you, it's okay, we'll let you use our services, or who says, no, you're not us, go away?
So the struggle right now is, and that's a good question, the way that the system is, there's not a way to change a lot of stuff in the system. The applicant tracking system, it's called NeoGov. The health districts could have the opportunity to just get our own contract with NeoGov and go through that route for our recruitment, postings, our job postings. The other stuff that you're referring to, like the job classifications, the state is not saying, okay, you can do this. I'm saying this stuff is already established, it's public record, and it makes sense for us to continue following that.
It's a good source.
So we don't have internal resources right now, especially with this late date of trying to transition all this to establish our entire own HR system. That could easily be one full-time employee that we don't have to do all of that stuff. And so the established systems, that we can easily go, it's public record, we can see the job classification, we can see the pay grades. That's what I'm proposing, is that we continue to use that information, at least for now.
Commissioner Botts, did you have something?
No, I was gonna just mention that, you know, some things like Percy dictate on how we have to do business. As far as time off, like we're pushing it over here. you know,
Yeah.
9 months, and you have to have 30 days off before you can come back.
Okay, are there any questions up until this point?
Just kind of a general question. Is this an action item then today?
It is.
Okay. Are we approving this document as written? Or is this a conceptual?
I would say it's a conceptual that you agree with the concepts, you know, that I have in here. And then again, next month I will come back and integrate the two and present the final policy manual for formal approval. But I guess I just need to know today, are you in agreement with the direction I'm heading? Because we need to start having more detailed conversations with our employees, because this could affect many employees' decisions of whether they want to stay with Eastern Iowa Public Health, or if they want to move on to a different state agency and maintain some of those other benefits that they've had. So what I would like to do is at least have buy-in for the direction we're moving, so we can have those conversations with staff starting next week would be my goal. And then again, come back next month with a formal, complete employee handbook for your approval.
We don't lose ability to continue our employees' participation in Percy.
Correct.
There were some typos and a few things that, as I read it.
So
word for word.
pass those to me. I'd love to see them, and we'll get them corrected as we
That
put it
was-
into final.
that's-
So,
Real crux of my question. So they're not important. They are important to the final document, so.
okay, thank you. Okay, compensation and benefit pieces, and this is where I want to have some more conversation. I just included in here that each spring, every year the board sets a budget. We have historically developed a compensation plan. It would be my plan to continue developing a compensation plan and having the board's approval on that we include in budget as we develop it each year. And included in our compensation plan already is that we have the ability to do some of these other, you know, salary adjustments as needed. Retention bonuses, a hard to fill position. Sometimes we have to offer a higher wage than, you know, the entry, if it's a hard to fill position, or if we have compression issues, we look at other people, like the example I gave of a new employee coming in at a higher rate than someone that's been here for many years. Sometimes we have to do some adjustments like that. And that has been our practice, and I would continue that practice. As far as sick and vacation leave, I'm proposing that nothing changes, and again, because we're still part of the state's, the state controller that manages those leave accruals and stuff, we don't have an option to change that if we're going to stay with the state system. And so I am proposing that we just stay the same. The vacation and sick leave accrual maintains the same as what's outlined by the Division of Human Resources. One thing that I wanted to talk about is this that says that the Eastern Iowa Public Health will accept transfer of vacation and sick leave balances for employees transferring to our agency from another health district. So prior to March 1st, if I was to go to a different state agency, my leave balances would follow me to that agency. Starting March 1st, that will cease. Because again, we're not state employees. State agencies will not accept that liability. And there's been discussion about the 7 health districts though, that we are interested, if the board gives approval, that we would still continue that practice between health districts. And I'll just tell you one example. I mean, Aaron came to us from another health district. So there's a benefit to doing that we can attract talent from other health districts. There's other conversation about in some other districts in the Treasure Valley that get a lot of people that go from the state health and welfare office to local public health. And so they're having conversations about whether or not they'll be allowed to accept those balances, because a recruitment tool, if they're not allowed to do that, it's going to be significant. But we don't get a lot of people coming from health and welfare to us. It's usually we lose people to go to health and welfare. But if the board is agreeable, I would like to include this, that we will accept leave balances from other health districts. Administratively, this is something that has not been able to be done in the past. It was solely to the discretion of the Division of Human Resources and the governor. But I've included here that me or the board can approve administrative leave for, for what they deem appropriate. As far as holidays, I included just the same 11 holidays that are currently observed through the state system.
No, go ahead.
Mr. Chairman, backing up just a little bit on leave. Is
Which
in our other handbook, is there any consideration for bereavement?
We have not included that in the past, no. And if the board wants to include that, we certainly can have that conversation.
And have we, or do we have in our other handbook, the ability for our employees to help somebody else out with sick leave? I'll donate my sick leave to somebody because he's got.
Yeah, that's-
So that's right here. That is already in there. It used to be that only vacation leave could be donated to another employee to use for sick leave purposes. But that rule was changed at the state, and so employees can donate vacation or sick leave to another employee, and we would continue that practice.
Did we put a cap in there where you can't donate all of it?
And according with the DHR policies that are already in place.
Okay,
So
so there is
yes,
something
you have to
in place.
have a minimum number of hours, and I think there's a maximum that you can donate as well. It's not included in here, but it would be represented when we pull these off.
Thank you.
Okay,
Under 11 holidays, Juneteenth, is that in there?
that is,
Okay.
was recognized last year by the state, so it is
Understood.
included.
I had that same. So with that being said, I think the holiday should be listed for those people that don't know.
So, as I said, if this doesn't incorporate everything, that is already our employee handbook, and so I agree.
Well, excuse me, but I'm gonna keep throwing it out there because I don't have the handbook in
Yep.
front of me.
No, I think that's good
Yeah.
discussion, Wayne, appreciate
And I know that
that.
there are a lot of counties out there that didn't accept
Yeah.
Juneteenth. And we're one.
And I was gonna circle back, but maybe we'll just take a moment. The bereavement, you have that in your county.
Yes, we do.
What is the time frame? I'm not sure we do in our
I
county.
think in Madison County, it's 3 days, if I recall.
In Bonneville County, I don't think we do.
The guy there in the end of our county.
5 days on Custer County.
By, and in current state policy, it's up to 5 days, they specify which relatives it counts for, and it depends on how far away they are. So if it's in the same city, it's less days, if they're a lot further away, it's plenty complicated, but
But they're allowed to use their sick leave for it, or approved
Yeah.
leave. It's not separate paid leave.
yeah, just then you get used sick leave.
On hours, you can use accrued vacation time. Not sick leave.
So it's not paid bereavement leave, really.
The 5 days is,
Oh, we've got 5?
yeah, we got 5 days. And then over and above that,
Okay,
when you're talking about, you gotta go extra days farther away or whatever,
Then they can use vacation.
then they can use vacation. Because you can't use sick leave, because you can't say, I'm not gonna be here next Wednesday because I'm gonna be sick. That doesn't work right.
Well, again, for sick leave, I guess not accruals, but not for the specific use of sick leave, we could make some adjustments to our policy.
I mean, it makes sense, that you can't say I'm gonna be sick next week. Which we've had people try and do that.
We don't have a distinction between
Yeah,
sick and vacation.
PTO, so.
Personal time off, that's whatever you got.
And one of our limitations is as long as we stay with the controller's office for our county, there's a lot of policy infrastructure built into the accounting system itself.
Does that need to be spelled out? Is it, when we have a blanket statement like,
As the holidays, they pretty much, well, it's on your time sheet. That's on what they take, that's fine.
but when we have a policy like on page 6, in accordance with Idaho Department of Human Resources leave donation policy, do we need to be particular, do we have that spelled out somewhere, what that policy is, or is it the employee's responsibility to go look that up?
So in the past, in our other employee handbook, it linked to that policy, it linked to it. We could write it out, but if the policy changes, then we have to update our handbook. If we link to it, then it's the most current policy that's in effect at the time.
That would increase the document where it doesn't.
Is there any strong feeling about the bereavement? I mean, I like to work, you can use sick for it, right? I mean, that,
And that's what our employees are used to. Okay, jury duty. Currently, I did include leave time for jury duty. I will tell you that the state's policy allows paid time off for which otherwise the employee would have worked. I capped it a little bit more, so this is up for dialogue. I put up to 40 hours a week for up to 30 days. But during the time they would have otherwise been scheduled to work. So no more than 40 hours for a month time. There's no cap in the state's policy. And it would only be allowed for time that they were scheduled to work. If they were part-time employee, they wouldn't get 40 hours a day.
I'm not sure about the cap. I mean, that's above and beyond the employee's ability to determine, right? I mean, if they are unlucky enough to get on the line, why did you put the cap in?
Looking what some other districts have done.
Right. Thoughts?
About it, they don't have any choice. Once they're appointed on that jury, whatever happens, happens. I guess you could get off and say, sorry, I gotta go to work, but I don't.
I think most judges.
I guess I don't think the cap thing
That's
is.
not acceptable.
Yeah.
Excuse.
I guess I don't see the need for a cap. I don't think it happens that often.
Okay.
And if it does happen,
I feel that way too.
I'll take out the cap and just leave it at, just take out this last section.
They have to provide.
Okay,
The one question I have, is I've seen that, and I don't actually know, but some employers require whatever is paid, the person for jury duty turned over to the employer, and some don't. I don't even know how much, I've done jury duty twice, and get paid $10 a day. If that's still the case, then I'd say let's just.
so I'll tell you in the state policy, it says that the employee is allowed to keep whatever reimbursement they get from the first source. If we want to just, if we just, all we could say here is just that we'll follow the HR policy.
Jury pay hasn't kept track with insurance salary increases.
Okay. Military leave, I left as is what is outlined in state. That's 120 hours of paid military leave for federal service. I did not call it out in here, but in the state's HR policy for state military service, employees are just allowed to leave without pay and to come back to a position, their own position or one comparable. So there's two other types of leave that, actually three, that have been part of the state's benefit package. The first one is organ and bone marrow donation leave. And that allows 30 days of paid leave if someone donates a body organ, or 5 days for bone marrow donation. And I did not include that leave in our manual. The second one is paternal leave, paid 8 weeks of paternal leave. And I did not include that in our handbook either. And then the last one, which indicates it's a temporary benefit, is recently the governor implemented an executive order allowing state employees to receive pay up to 16 hours of pay per period to be a substitute teacher to help the schools during this time of shortages. And I did not include that. So that would be my recommendation to the board, but with a caveat that if we have any employee that is in one of these approved leaves as of February 28th, that we allow them to continue until the end of that benefit, but not approve any new ones past March 1.
Is there a sunset on that executive order of the governor?
I would have to go read it. I don't
Just
know.
yeah.
I think there is, because it was a temporary benefit.
Mr. Chairman, Jerry, so we're referring to FMLA,
No,
maternal?
no, it runs concurrent with that FMLA, but it's not the same. It's 8 weeks of paid leave.
It's in addition to sick leave
Yeah.
or vacation. If the leave is due to birth of a baby or adoption, they get an additional 8 weeks of paid time that doesn't impact any of their other paid leave balances. It's a huge benefit. Very costly.
So is it written in there that you have to be an employee for X amount of months?
I'm not proposing we do that.
Okay. So if somebody comes to work and works a week, then they're eligible for it.
No, because we're not offering it.
Oh, okay,
Yeah.
gotcha.
Okay. So the benefits, again, I didn't do a lot of stuff here, just refer back to the Office of Group Insurance because that is what they have access to for Percy, medical, dental, vision, life insurance. And then in the past, and this does come into play for Percy, credited state service. So effective March 1st and February 28th, we will be provided a report of our employees' credited state service hours, because that's what they have been accruing all these years. And then starting March 1st, they'll no longer get credited state service. And we changed that to credited service as just a health district employee, but it's basically the same thing. And that has to do with, leave accrual and all of that type of stuff. So it will just be not credited state service, just credited service. going forward through March 1st. They will continue that balance that they have with the state and then add on with discredited service. Okay, sick leave reinstatement. Currently, if an employee leaves employment of a state agency, including the health district, but they return to state service within 3 years, their sick leave that was forfeited at the time of their departure gets reinstated. I wanted to include that, but that I just want that to be known. And
How often does that happen?
not frequently, I would say. Can any of you help me with someone that has?
I want somebody that had got COVID temporarily.
It's not often.
You probably know one, can.
Our epidemiologist had worked there for a few years, left.
Yeah,
And
it was
bring back-
a number of years ago, but he went back east for 2 years. And I heard, I don't know what he's doing. And then he came back again.
I think it's a good thing because you regain all that experience they had before, so
There's value.
Mm-hmm.
gives them a good incentive to come back. Yeah.
Okay, moving on to employment policies, just talk about evaluations, that supervisors are expected to manage performance of their employees. We already have a process in place that we do, formal evaluations for employees at 3 and 6 months after hire, and then annually thereafter. So that it continues that.
Are they consistent with that?
Majority.
We got told to strike that in ours because it'd get us in trouble if we said we were gonna do it once every 6 months or once a year and then didn't get it done this year, and so next year, maybe we got it. So it was easier for Ivan and they said, it's good.
So you put it somewhere else as an expectation, but just not in the employee manual?
No, just the 6 month and the 1 year probation period is the only thing that's in there where you do interviews or evaluation.
So while we're talking probation period, we've gone back and forth on this because as we're moving to at will, there's really no need for a probationary period. And so I have not included anything in here that talks about that you have a probationary period of 6 months. It would still be our goal that we would, for the first 6 months or so of the job, an employee is learning the job and would work with them to get proficient in the job. But there really is no formal need to have a probationary period if we're moving in the at-will direction. Previously, after the 6 month probationary period, employees were at will during that time with the state, but then after that, they were, a classified employee. So just a.
Yeah, I mean, it seems right. It does really take away that mean when you're at will.
I agree with the probation comment. I'd also add, perhaps on the evaluation side, that maybe as with considering the labor shortages and maybe as we or some amalgamation of a state agency and a private agency that has a little bit more local control. And I appreciate Commissioner Butt's comment on let's not put it if we're not going to do it. Maybe we should do it. Like maybe take advantage of this opportunity as a manager to sit down and say, are you happy? Or this is an evaluation, I get that, but are you happy? Are you progressing? What can we do to keep you happy and keep you working with us here in the health department? I think there's going to be some real value to that in the years ahead as we look to find good people, hang on to good people, especially if they're willing to dig in and do this work with us. I think if we can encourage that and motivate that in any way, I think it's a long game. It's not a short game. But I think,
And I think it's only fair for the employee to know, are they performing well, or, are there issues identified? And just to have that, it should be an ongoing dialogue with your employees all the time, but just to really, and there are times it doesn't happen, that 6 months, 3 months goes by and, oh, we didn't get that, but it still is my expectation that we're doing that with our employees, to have that formal dialogue with them.
Mr. Chairman, conversation on ICRIP on that one, though, and I can appreciate what was said. I can appreciate that. But for the people, the supervisors that pull their people in and do those interviews, and then they terminate them next week. You know, it's like, well, wait a minute, you just gave them a great evaluation, and this week you want to terminate him, and there's nothing in his files other than he's done a great job. Makes it a little bit.
Yeah, there's a management issue, though.
Yeah, follow along with the governor's comment. Would there be value in the employee filling out the evaluation of their job and of their supervisor?
And we do some of that. We have a self-assessment tool that several divisions use when they're working with their employees on evaluations. And I think I don't know that we've had a formal evaluation of their supervisor each year, but it is that conversation, you know, what can I do? How am I supporting you? You know, that is part of the dialogue, but I don't know that it's been a formal process for all divisions. We can have a conversation about that.
A comment, Commissioner Butts, the statement there regarding that determination in a week after positive evaluation. Proper management does not allow that person to be terminated if there's that kind of, your file has to follow the actions. And that is the employee file becomes very important in that regard.
And we'll talk about that as we get to the disciplinary action piece.
So
If there's stuff that you want to stop on here, as I'm just scrolling through,
So on
just talks
the
about how we handle personnel files and employees' medical files.
personnel files, where are they held?
Personnel files are in human resources, and there is a separate file that includes their medical stuff, that is kept separate from their personnel file.
And the only reason I bring that up is if a supervisor is the only one that has the material in his or her office, and all of a sudden things start getting rough and things disappear. We're told that maybe our risk manager, which in our case is our clerk, told the original copy in the vault. The supervisor can have it, but you know, what happens when you get raised? Somebody gets wind that somebody's gonna get terminated, and then all of a sudden, all those files are gone, which we had happened twice in the last year.
No, it is our policy. Supervisors can keep copies of stuff, but the official document is the personnel file with human resources.
Okay, thank you.
You go back up a paragraph, up to personal information changes. I think we need to be a little more direct, that it is your responsibility to keep your physical email addresses. I appreciate being kind and considerate, and saying please, but in this day and age of electronic emails and all of that other stuff, it's easy to say I didn't know, I didn't receive that. And I just think it should be their responsibility.
I can do that. Resignations, this unexcused absences of 3 or more days, it has been consistent. That is how we function now. And this, I think I need to fix this date, because it is 2009, not 2000. What we were talking about earlier, that some employees may have the ability to use a portion of their insurance to go towards insurance, a portion of their sick leave to go towards insurance. At retiree benefits. Yeah, so I need to fix that language. And again, we don't have clarity on this yet, but I hope to before we finalize this policy. Reduction in force. Layoffs are necessary. We will evaluate positions to needed to conduct the ongoing or future work. Length of service may be a factor. We could use that seniority dates if we're if needed. Comply with the obligations under the Idaho Veterans Preference statute. Anyone that would be in a temporary position would be the first one to go, and then looking, if we're looking off, laying off regular employees, taking these things into consideration as we're doing that. And then we just have copied, federal FMLA information. Workers' compensation information. And then employee discipline. And this goes to Commissioner Dance's comments that it's still our responsibility as supervisors and managers to ensure that we are we have appropriate documentation. As we were talking about this the other day, it's costly for us to terminate an employee and try to recruit anyone and hire and train. It's costly. So we really prefer to provide employees feedback so they can improve their performance and maintain a job with us. It's both of our benefit. And so we have followed progressive discipline in the past, and it's my intent that we continue to do that. Typically we have done a verbal warning, a written warning. It's it has been historically very rare that we do a suspension without pay, or a demotion or a dismissal. But as outlined in here, even though we're at will, if something that were a very egregious act, we could just terminate employee without going through this process. But best practices is to follow this disciplinary process and work with employees to help them improve their performance before we get to the point of dismissal. And then, Commissioner Butts, thank you for the comment on the name clearing. As I was having a conversation with Mike King on this, he had indicated a need to have that in there. So I guess I'm going to follow up on that.
We had it in our previous policy, but after the last two lawsuits, and we went to at will, they said, take it out.
Okay.
But explain that to me. What's the harm with the name clearing? I mean, because it's, we have it in ours.
If you've already made up the decision that you're going to terminate the person and you've given the reason, then why allow him to come in and say, I was not drunk when I wrecked that truck? But yet the test said, yeah, you were 2.0. At will, if they walk in the door and they look at you wrong, at will, you get rid of it. Yes, it's a good idea to follow the approval warning and all the rest of it, but they've also found in that too, and I think I've talked about it before, where if give an evaluation, he's doing a great job, and they can fire him next week, what happened? But you have the ability because it's accurate.
Well, I can just tell you that it would be my expectation if the manager was coming to me proposing termination, I would expect that there be solid reasons for doing so. Okay, that's the end of the handbook. So what I heard today is we want to change the jury leave and remove the limitation on that. In the information on your personal contact, that it's employee's responsibility for keeping that up to date. And then is there a preference one way or another of the name clearing hearing? Do you want me to remove it? Do you want me to seek additional consultation on that?
Any thoughts? I mean, based on Commissioner Butt's recent experience with iCrimp, I would say we remove it, right? Anyone have any objection to that?
I'm sorry.
Go ahead.
No, it's a different subject.
Okay, anybody have any objection to removing that?
Why, what's its value? I've never been involved. In 40 years of HR, I've never been involved in a name clearing. When it gets to that point, I just need a little bit of education on what a name clearing.
We've continued it at ours and we've talked about it. And it's been used a couple of times in ours, frankly.
Successful.
It's just an opportunity to have the separation a little less contentious. You know, once it's done and over with, you might have less retribution from the employee. They may speak less ill of their former employee out in the public if they've had a chance to come before the what's the word I'm trying to say, the boss, you know, can't find the right word, and say, look, you know, this is why this happened this way. I understand why the complaint was brought against me. I understand why you're firing me, but I want you to understand why this happened. And so we separate with a little less hard feelings with each other.
So for us, Mr. Chairman, in a small community, a name clearing happened before termination. And it was one of those deals where the supervisor never liked me. He's picked on me all the time. This is his way of getting even. And because it's a small community, I mean, if he goes out there and tells everybody that I continuously ran that motor with a low tire, who's going to hire me in the field that I'm there for? So then we would meet with the supervisor and say, well, we met with him in a name clearing. We would appreciate it, you know, if you didn't run around telling everybody what you feel. We don't want to hear that in our small community. Everybody has the right to a job and, you know, bring home a paycheck. But for us,
I can see that, and if I could, you know, wants it removed, I'd be fine that way. Does anybody else have any feelings?
Check with iCrimp and see.
Why don't you check with them?
In my experience, and I've been out of the world, you know, formal workforce for a long time, I have not run across that being an option. That's a new option to me, and I'm going, it all goes back, and this is my training, you have to manage the personnel file. And that personnel file has to coincide with the reasoning for the dismissal. End of story. So it's a new concept to me.
And I just want to share that, you know, I don't want our employees to feel like any day they're going to show up and we're going to terminate them. That is certainly not the intent of this. We will continue, again, like you just said, Commissioner, to manage performance, and they will be made aware if they're not performing. And it would be, again, my desire that as much as possible, we go through that progressive discipline process, unless it is something egregious that constitutes or justifies, you know, immediate termination. So we value our employees, that we don't want them to be feeling like their job's at risk every single day. That is not the intent at all.
Any other discussion? We probably then do need a. Go
so
ahead.
was that the only thing? I mean, we talked about bereavement. We talked about.
So I didn't get the sense we were going to add.
The bereavement, yeah, I didn't get the feeling we were going to add that either.
And listening of the holidays. And I guess one thing that I didn't add, in the final draft, there will be a page for them to sign.
Yes, so, and that's part of the conversations that we want to start having next week to educate employees on this wayward moving. When the final manual is ready, every employee will be provided with a formal one and an attestation form that they have read the manual and have had opportunity to ask any questions about.
So I think what you're asking today is just support to continue. Nothing is really in stone until we take it up at the next meeting, if that's when it's ready.
Yeah. The biggest pieces are, the at-will direction that we're moving and the leads that we've talked about, so I can communicate that to staff.
Accept the motion, if anybody's so inclined.
I think that motion, Mr. Chair, that we move forward with the intent that we outlined here with our first motion policy.
Okay, second. Second from Commissioner Butts. Any discussion? And all in favor, say aye.
Aye.
Is there anyone opposed? Okay, thank you.
Thank you all. I think we're at a point now we can break for lunch.
Okay,
Until about 12:15. And then we'll resume.
okay, sounds great.
So.
Do you anticipate us going there and coming up? Oh, wait, come here.
So Leo, we're gonna go on mute till 12:15.
Say that again. I'm sorry.
We're going on break until 12:15.
Okay, thank you.
Back to order then. And we'll go next to item number 7 on our agenda, which is drug overdose prevention.
So I just have a couple updates to share in regards to the Idaho opioid settlement agreement. We got word this week that 100% of Idaho cities and counties have signed on to participate. However, there are 25 special districts that are also part of the equation. That includes like school districts, fire districts, hospital districts that have a population of over 25,000. Apparently there are about 25 of those in Idaho, and about half of them have signed on. They don't get any funding for it, but they have to agree not to sue the pharmaceutical companies as well. It sounds like we may see the first payment to Idaho around April 1st. And I was told that there are other lawsuits that are moving forward. And so this initial settlement agreement that's been drafted will be used as the template for all future ones that may come to us. So things are moving forward. I would say in our March meeting, we can bring to you a more concrete presentation on what we feel we should do in our health district with the funding, and have some discussion about that. But things are moving forward.
Any questions on that? I think counties have been all very involved in this.
So Mallory is going to do a presentation on opioids. I'm going to switch places so you can control your how you want to do the slides. So give me just a minute to.
While you're switching that over, the district started to compile things that counties could do with the opioid settlement money, some suggestions or ideas, or I know you don't want to appear to be, hey, we're going to tell you how to spend that money, but I know several counties are going to this.
So I've not heard of anything, it really just hasn't been a topic of discussion. But as I shared early on, I would like for us in our health district to get all the parties that are participating together, and let's have some conversation, and also talk about, state level objectives, and where does it make the most sense for our local district for those that are participating. So we'll talk about that at our March meeting as well. Scroll up and down. We start with an introduction or something like.
My name is Mallory Johnson. I do our drug overdose prevention program and coordinate that. I was asked to come and talk about Narcan, and also I wanted to talk about opioids, especially with the opioid settlement coming up. I wanted to talk about what opioids are so that everyone can understand them, and then how to respond to an opioid overdose, and then the resources that we already currently have available in the community to respond right now. And all these slides are on the in the document. So at any time, if you guys want to review them later on, you can go ahead and. This first, I'm going to just talk about the impact of opioids and the impact on the United States. So the opioid crisis total economic cost between 2015 and 2018 was estimated to be about 231 billion, with 150 billion of that being employer costs. And then 71% of the United States employers reported that they have been affected by employees of prescription opioids in some way. These are the drug overdose deaths that we have from 2020 in the whole state of Idaho that are specifically related to opioids. So 164 deaths, and then over 1 million prescriptions were written in Idaho for opioids. with over 4,500 emergency department visits in 2020. So now I'm just going to go into opioids and talk about what they are. There are 3 different classes of opioids. Your opiates are your natural opioids, your semi-synthetic, and your synthetic. And prescription and illicit opioids can fall under these different categories. So with your prescription opioids, these are prescribed by a healthcare provider. They're used for treatment to moderate or severe short-term or chronic pain. And there are different risks involved, even though they are prescribed by a healthcare provider. Those could be things like addiction or dependence, overdose or death, pregnancy complications, and the different side effects such as sedation, constipation, or respiratory depression. And the chart over here on the right-hand side just shows some of the generic first branding. I do this training with law enforcement, with other first responders, with people in the community, the public, the recovery groups. And I've had lots of times where I've gone and I've trained and people have told me I was prescribed Vicodin or I was prescribed Percocet, and I had no idea that it was an opioid. And if people don't know what it is that their doctor's prescribing them, then how are they supposed to know how to properly store it, dispose of it, any of those things? And then also tramadol is an opioid, and that one a lot lately has come up that people have told me they did not know that tramadol was an opioid. So this chart's just really nice so that you can look at the generic and the brand names and know what it is that you are being prescribed. Tramadol is a synthetic opioid.
And it does what?
It's used for pain. And they have different, there could be like a release that allows it to go pain for like multiple hours instead of like a short term. These are what a couple of the common opioids look like. There's a really great tool if you were ever to find some sort of medication lying around somewhere and you were wondering what it was, whether it's for a job or in your home or anything like that. You can actually go into your search engine and just type in drug identifier, and it'll pull up a drug identifier website. And you can type in the shape, the size, the number, which is really great. But we're going to talk about in just a little bit. Unfortunately, there are the counterfeit pills that I've created that look a lot like the common opioids. These are just what some of them look like. So if you're prescribed them, you'll know. 38 people die in the United States every single day from overdoses that involve prescription opioids. And then prescription fentanyl. So prescription fentanyl, it is a synthetic opioid pain reliever. It's up to 100 times more potent than morphine, so it's quite potent. It is a scheduled prescription. It's used for very severe pain, so think of cancer pain treatment. And there's different types that it can come in. So these are just some examples of a patch and a lozenge. But it's always important when you are prescribed medication to talk to your doctor. Ask them about the prescription, ask them how long you need to be on that prescription, why you need to be on it. And then also talking to them about co-prescribing naloxone if you're prescribed an opioid. Anyone in the state of Idaho is allowed to have naloxone, and so you can always ask your doctor to co-prescribe it. And then also talking to your doctor about alternative pain treatment. So these could be things like over-the-counter medication, physical therapy, acupuncture, massage, exercise, cognitive behavioral therapy. And some options have fewer side effects and risks. Yeah.
What would be the purpose for having them prescribe naloxone at the same time?
It's not just illicit opioids that people can overdose on. So it's prescription as well. So if the person accidentally takes one too many because they forgot the last time they took their prescription opioid, or if they were taking it with a contradictory medication, something like Xanax, or if they were prescribed something that contradicts with it, it's great to have that naloxone in their home just in case, because they're taking home that opioid with them. So then they just have it. It's not just for illicit overdoses, which I think sometimes is the misconception. So you can always ask, and anyone can have it in the state of Idaho. We have the Idaho Naloxone Access Law, which makes it so that anybody can have it, anybody can carry it.
Do doctors tell people that?
I just think it probably depends on the doctor and how much they know. But one thing that our program does is work with prescribers and make sure that they have information, they have resources to share with the public when they come in. Good questions. These are your illicit opioids. So illicit opioids are things like your heroin and illicitly manufactured fentanyl. Methamphetamine is not an opioid, and that's just important to know because if somebody is having an overdose from a different substance that's not an opioid, the naloxone is not going to reverse it. It's not going to cause any harm, so you can go ahead and administer it when in doubt if you suspect a drug overdose, but it's only going to reverse an opioid overdose. And methamphetamine is not an opioid. These are some pictures of your heroin. It's rapidly acting, highly addictive. The lethal dose being about 30 milligrams. And then your fentanyl. So on the left-hand side of this picture, you can see that these fentanyl pills actually look like little oxycodone pills. So they're counterfeit oxycodone. There are different names for it. One of the names that's going around our community is 30/30s for it. These are sold through the legal drug market for their heroin-like effects. The issue is that oftentimes they're mixed with different substances, and sometimes the person does know it's in the substance, and sometimes they do not know it's in the substance. And the lethal dose of this would be about 2 milligrams. So if you have a pencil on your table and you look at the tiny tip on your pencil, that's about 2 milligrams. It's really small, very potent, or just that little mark right next to the penny. These are some of the counterfeit pills. So your oxycodone, there's your authentic and your counterfeit. And in this picture, it's really easy to see, oh, well, one's white, one's blue. But it really just depends on what the person is producing it, how they're producing it, what stamp they have and everything. So it can actually be quite hard if you're buying a substance from somebody to know if it's counterfeit or authentic. And that's been the problem lately, so there's been a lot of counterfeit pills going around. And then there's a counterfeit Xanax, not authentic Xanax. And as I mentioned earlier, when you're taking something like a Xanax or some sort of sedative with an opioid such as fentanyl, it creates a lot of risk. So that's quite risky. Illicit opioids do have the same risk of prescription opioids, so your addiction, dependence, overdose or death, pregnancy complications, and different side effects. But the unique risk that it's not regulated, and it can be quite potent. So I like to think of if we had like a big bowl of flour, we had some pink glitter, and you put the pink glitter and then you stir it up and you lay it out. And there's going to be some that have a little bit of glitter, some that have none, some that have a lot. When you go to your pharmacist, they have to regulate everything. So if they tell you it has 5 milligrams in it, it has 5 milligrams in it. It's regulated, right? They're very careful about it. When it's an illicit substance, you can't always tell and measure how much is in it. This is a side-by-side look of the lethal dose of heroin next to fentanyl, next to carfentanil. Carfentanil is a fentanyl analog. There's all sorts of types of fentanyl analogs. Some of them are more potent than fentanyl, and some of them are less. Carfentanil is actually 100 times more potent than fentanyl, so that makes it 10,000 times more potent than morphine. It's actually used as like a really large animal tranquilizer. So think of an elephant tranquilizer. And unfortunately, this is being laced into different substances as well. So 136 people die every day from opioid overdoses. That include your prescription and your illicit in the United States. So then who's at risk? Anyone taking prescription opioids, someone taking high doses of prescription opioids, especially if they're prescribed a high dose or a long active dose right away. Contradictory medications, but this could also be a contradictory substance such as alcohol. History of misusing prescription drugs, and then people who use heroin. These are some of the overdose risk factors, and it's important to recognize that not everybody is the same. So this would be an example of somebody who has poor physical health, is younger in age, has a history of substance use, their tolerance is smaller. So how a substance affects this person is going to be different than it affects somebody else. This chart, I'm just trying to make it so. This shows the 3 waves in the opioid overdose deaths. So in 1999, there were a bigger wave in your prescription opioids. And then we have things like the prescription drug monitoring program, and doctors are hopefully talking more to their patients. So there's different things that we have now, and that's kind of leveled that out. In 2010, there's an increase in heroin overdose deaths, and then 2013 was your increase in synthetic opioid overdose deaths. As you can see in 2019, that one just keeps going up. Those are things like your fentanyl, your tramadol. So I just wanted to show a little bit of county data and public health specific data. District-wide in District 7 in 2020, we had 29 overdose deaths. And this is how they break down into the county. So Bonneville County has most of the overdose deaths, but you can see in 2020, there were 22 in Bonneville County, 2 in Fremont, 1 in Jefferson, 2 in Madison, and 2 in Teton. So it is affecting our health district. This is just a little bit of information on the opioid overdoses and COVID-19. So the middle one talks about how while overdose deaths were already increasing in the months preceding the COVID-19 pandemic, the latest numbers suggest an acceleration in the overdose deaths. And then your synthetic opioids, mainly your fentanyl, appear to be the primary drivers of these increasing overdose deaths. This is some information about what the Drug Enforcement Agency put out in September of 2021. They've been collecting a lot of fake prescription pills that contain fentanyl and also methamphetamine. And 2 out of every 5 of those fake pills that they've tested actually contain the lethal dose, so that at least 2 milligram dose that could potentially kill someone. So 2 out of every 5 of the ones that they're testing have that lethal dose. And they've collected more than 9.5 million counterfeit pills in 2021. There's different options to safely store and dispose of your prescription opioids, and we have some of those here. So the timer cups are ones that you could purchase online. They count down the minutes and hours of when your bottle was last opened. Really great for starting a conversation if you see that it was opened and you know you didn't open it, but also really great for people who forget the last time that they opened it. So that way they're not taking it when they're not supposed to be taking it. And then these are something that we have here at the health department. These are the vault boxes. This is the medium. We have medium and large available, but they're just a combination lock. It opens up and you can store your prescription medications in there. And then the large is a little bit longer and a little bit shorter, but they're great. They have a code that you can set the combination inside. It's really easy and just a smart way if you're having people come in and out of your house. That way you don't have to worry about them getting to your prescription opioids. And like I said, we have these available. So if anyone here today wants one, I'd be happy to grab one for you. So those are different ways to safely store. And then when you're done with your prescription opioids or if they're expired, a great thing is to get rid of them so that it can't get into the hands of someone who will misuse them. So the gold standard of prescription drug disposal is using a Dropbox location. And we have lots of these Dropbox locations throughout our counties. I have a whole list at the end of this that talks about which county and where the Dropboxes are, but most of them are at places like your sheriff's office and different pharmacies. So here in town, over by the Greenbelt at the law enforcement building on Capitol Ave, they have a Dropbox. So you can just go in there and drop off your prescription medications. At some of the Walgreens around here, you can go in there and drop off your prescription medications. So that's a gold standard to kind of get rid of those medications and get them out of the house. Not everyone has Dropbox locations near them, or some of our communities, they're only in certain areas. And so you can get rid of them in your home. And you can look at this. This just talks about how to get rid of them in your home. There is an FDA flush list. This is very short. If you've seen the list of medications, this is a very short amount of them. But these are mainly your opioids that the FDA says they're so potent and can be so harmful to somebody if they get into the wrong hands, that these ones are allowed to be flushed, but you don't want to flush every single thing. So we have these available at the health department for community members throughout the health district as well. These are called Viterra drug deactivation pouches. We have medium and large. This is your medium. They're really simple and easy to use. So you can put in pills, films, liquid patches in here. So your medium takes 45 pills or films, 6 ounces of liquid or 6 fentanyl patches or any type of other patch. And if you put a patch, you just would put it on like a Kleenex and then drop it in. Once you have your medications in here, and you can fill it up halfway with warm water. That warm water activates the carbon pod that's inside of here. And then the carbon pod will actually break down and deactivate the medication and render it unusable. Then it'll kind of bubble and fizz for 30 seconds. You seal it, you shake it, you throw it in the trash can. This is a really great option because if somebody just throws their prescription medication in the trash can, say when the trash comes by and it falls out, right? Or somebody goes and digs through it, it can be potentially misused. Or accidentally found by a child or somebody who doesn't know what it is and accidentally takes it. And so this is really great. It actually renders that medication unusable. If you were to open it up and try to get the medication out of it, and you could not then use that medication for misuse purposes. So a really great option to use. And like I said, we have these available. So again, if anybody wants one of these, I'd be happy to bring them. But we have medium and large available. They're really easy and convenient. And you can also put over-the-counter substances in there. So there's different over-the-counter substances such as cough medicine that can be misused. So if you have some of that, you can even mix that in there. You can put in different things as long as it's not iron or lithium, and as long as it doesn't, you don't put a sharp in here. And then for sharks, the disposable sharks, we do have a disposable exchange program here where you can purchase a box and then you fill it up. So say you're diabetic and have insulin or other things like that. You fill it up, then you come back, you pay the disposal fee, and you get a brand new box. So we have this option. Or for people who want to dispose of it in their residential trash, they can, and this talks about how, but you really need to put it into a container that's not going to prick somebody or cause other issues. So in a container that's hard or thick. So not something like a water bottle, but something more like a laundry detergent container. So what is naloxone? Naloxone is a medication that temporarily reverses an opioid overdose. It does this by restoring someone's breathing. There's two main forms that are available, your intranasal and your intramuscular, and they last for about 30 to 60 minutes. And this is how they work. So we all have different opioid receptors in our brain. When somebody's using opioids and too many opioids attached to those opioid receptors, it actually slows them and stops the breathing. And then when it does that, the person can't breathe, and that's what causes the overdose. Naloxone is really great in the fact that it actually has a stronger connection to the opioid receptors in the brain than the opioid itself. It's stronger, but it's shorter. It only lasts for about 30 to 60 minutes. But it can temporarily push those opioids off those opioid receptors and restore that person's breathing, which reverses that overdose. This is the list of who should carry it. Really, like I said earlier, we have the Idaho Naloxone Access Law, so anybody who wants to carry it can carry it. Anyone who wants to administer it can administer it. You're covered by that law, but especially if anyone is prescribed opioids and has other risk factors or may have reason to encounter someone experiencing opioid overdose or anyone who's using illicit opioids. You can go to your pharmacist and get it. You can have your doctor write a script for it, but there's also different places where you can get it for free. So you can always check with your insurance provider. Idaho Harm Reduction Project and Soldiers of Hope, which Soldiers of Hope is here in town, provide it. And then organizations, so Idaho Department of Health and Welfare. And when I work with our law enforcement, I go look through Idaho Department of Health and Welfare to make sure that all of our law enforcement has naloxone, and with our EMS agencies. So that's a really great opportunity to get it for our first responders. And then anybody who accepts, we have these overdose rescue kits, so people who accept an overdose rescue kit can get it from Idaho Department of Health and Welfare. And there's also a Narcan community program grant through Narcan itself. Because it is a prescription, it does have to be stored properly. And probably the most important one is keeping it at room temperature, especially right now when it's colder in the evening. If somebody keeps the Narcan in their car, it's going to freeze. And then if it freezes, you can still use it, but you have to wait for it to be thawed. And sometimes you don't have 10, 15 minutes for it to be thawed to administer it. So keeping it at room temperature, letting people know where it's stored in case of an emergency, knowing the shelf life, replacing it as needed, and keeping it out of the reach of children. This is just a little bit of information on our Idaho Good Samaritan Law. So I talked about the Idaho Naloxone Access Law. The Idaho Good Samaritan Law, there's a couple different parts to it. But the part I wanted to talk about is the part that encourages people to call for help. So what was happening is people weren't calling for help when there was an overdose situation because they didn't want to get in trouble and people were dying. And so what this does is it encourages people to call for help for them or someone else that has experienced a drug-related emergency, such as an overdose. What it does is it protects the caller and the person who's overdosing. So just those two people, and it gives them immunity from being charged and prosecuted for these three specific crimes: possession of a controlled substance, possession of drug paraphernalia, and being under the influence of a controlled substance. That's only these three specific crimes, and though it gives immunity for these, there are limitations. So that individual, either one of them, the one calling or the one overdosing, is on probation or parole. That status can be revoked or modified. The individuals could be detained and held even if they're not charged, and they could be charged with other crimes. But the intent of this was really just to make it so that people were calling for help so that somebody's life could be saved, and then hopefully we can get people to treatment. So the steps on how to respond to an opioid overdose. I wanted everyone to understand how exactly to use the Narcan or the intramuscular naloxone. So the first thing you would do is assess if there's an opioid overdose. So if somebody's having a slow heartbeat, slow regular stop breathing, they're unresponsive to voice or touch, clammy pale skin, pinpoint pupils, blue lips or skin. A lot of these look like some other medical emergencies. But like I said earlier, if you suspect it's a drug overdose, when in doubt, you can always administer naloxone. It's not going to harm them negatively if it's not an opioid overdose. It just won't reverse whatever's going on. Then after you assess if it's an overdose, calling 911. If there's two of you in the room, having one person call 911 while the other person administers naloxone. If there's only one, call 911. The next thing, a lot of us have smartphones or tablets these days that we can tell to call 911 as we're administering. But making sure that 911 knows right away, letting them know where you are, speaking clearly and calmly, and then giving your naloxone. So this is what your intranasal Narcan looks like. This is your 4 milligram. It comes in a box with 2 doses. They just look like this. There is a brand new one called Auto that just came out. That's an 8 milligram dose that the Department of Health and Welfare has recently gotten in. Which is a great option, especially for law enforcement. So that way they can have 8 milligrams right away instead of having to give 4 milligrams and then wait for another 4. But how this works is you would just peel off the back of this. So you just peel it, and then you would place this in the nostril and press the plunger in. So peel, place, press, really simple and easy. Say you have to administer another dose. Say after 2 or 3 minutes, the person doesn't show signs of that overdose reversing, you would just switch which side you put the Narcan in. So you just move to the next nostril, peel, place, press. If you have to administer a third, you just keep going back and forth. I have heard of times where law enforcement has had to give 5 to 6 doses of Narcan in order to reverse that overdose. There is no limit of how many that you can give. You just keep giving until EMS would arrive or until you run out, if the person isn't responding. And then this is your intramuscular. So it comes in a vial, and to use this one, you just pop off the top of it, you draw out the whole entire vial and inject it at a 90-degree angle into the muscular area. And whether it's your intranasal or your intramuscular, as always, if there's no response after 2 to 3 minutes, you want to administer another dose.
Can I ask you a question there? How long does it take like with the nasal? I mean, when do you know if you've given them enough?
So if the person starts to come out of that overdose, if they start breathing again, then you know. But they can, because it's only effective for about 30 to 60 minutes, they can come out of that overdose, start breathing again. But if law enforcement or EMS aren't there yet, and they have so many opioids, those opioids reattach. So in a case like that, you'd want to re-administer. I have heard that intramuscular, because of the mode of administration, can be faster than the 4 milligram dose. And so I think that's why this other organization, Fox Auto, created the 8 milligram dose that the Department of Health and Welfare is trying to now have available, especially for law enforcement. So they could give the 8 milligram dose right away, which their hope is that that helps faster and is the same speed as the intramuscular.
Maybe to further answer the question, my experience with naloxone administration, like on a medical level, maybe 10 to 15 seconds.
Exactly.
If you haven't noticed a response in 30 seconds, I would administer the other dose.
You've probably given it before, when.
Yes, I have.
Sometimes it works a little too well and you
Yeah.
go back a little sleepy sleep, so. Very quick, you really wake up.
And yeah,
Wake up angry.
Depends on the situation.
Yeah, I can't remember if this is in your thing. Yeah, if you ever do, they can come out of it a little bit unbad. Yeah.
And I do talk about some of the different symptoms of acute opioid withdrawal, which happens when you administer naloxone and when it works effectively. And so they could be confused, they could not know what's going on, they could leave and think nothing happened, they don't have any recollection of the overdose. They could be irritable, restless, that it just depends on the situation.
And sometimes they're in
they're taking it, it's prescribed for an appropriate reason, and you have underlying pain, and suddenly they can erase any pain coverage, so they can wake up and be in a lot of pain and really uncomfortable. It's tricky, but life saving, still life saving. So.
Yes.
I'm assuming that the last really quick. It only lasts 30 minutes, something else gonna happen soon.
Yeah, because it does, often it will, the won't last, and so for significant overdoses, we have to put them on a drip, a continuous infusion for hours of it, and kind of adjust it and titrate it so that they wake up slowly, and yeah, so this usually isn't, this wouldn't be something I'd want to do, and just call it good and get back on with the day. I don't want an ambulance there, I want to be heading to the hospital.
So if at any time you administer naloxone, you always want to call 911 to make sure that EMS gets there. So that way they can transport them to make sure that they get the care that they need. After somebody is given naloxone, you do want to make sure that they're breathing and just making sure that, that they're breathing so that way the oxygen can flow throughout their brain. After the person's breathing, it's important to put them in recovery position. Essentially, this is just laying them on their side. So that way, if they do vomit or anything, they don't then choke on it. And especially if you have to leave for any reason and you can't stay with the person, it's best to put them on their side if you have to leave. And these are some of the signs of acute opioid withdrawal that I was talking about. So the body aches, fever, sneezing, runny nose, weakness, yawning, nervousness, restlessness, irritability. There are different acute opioid withdrawal symptoms that somebody could experience because of giving Narcan. But just because somebody could experience it, I don't want people to be afraid to give Narcan. I mean, it is a life-saving thing, so everyone's going to respond to it differently. But just being aware of it is important, so that way maybe you can give them a little bit of space after you administer things like that. And then opioid use disorder. So opioid use disorder is a disease. Diabetes is a disease that causes damage to the pancreas. Opioid use disorder actually causes damage to the brain. But because it's not always seen as a disease, there's a lot of stigma attached to it. And that stigma can enhance or reinstate drug use. And it can also reduce someone's willingness to go and seek treatment or talk to somebody and get help for their opioid use disorder or substance use disorder. So there's different things that we can use. So the words that we say really do matter. So instead of calling someone a drug addict, a person with a substance use disorder, or instead of a drug user or a drug abuser, somebody who uses or a person who uses and injects drugs. And really what this does is it just uses person first language. So it's putting that person before their diagnosis. So they're a patient instead of a user, a person in recovery instead of a former addict. And then the resources that we have. So like I mentioned, we have these Terra pouches available. We have the lock boxes available. Something else that we created is this Eastern Idaho Community Resource QR code. We have them available on stickers, magnets, window clings. But when you scan this, it's due to our website that has a map of different substance use prevention and recovery resources, housing resources, medical facilities, where are all those prescription take backs. It has our educational, it has some mental health and behavioral health resources, financial and food assistance. So just a lot of different resources that can help connect somebody to the care that they need. We also have some treatment resources listed on there. And the great thing about this QR code is that we can go and update it, and somebody can have the QR code and they can scan it tomorrow after we update it today, and they'll have all that new information on there. We were able to send these out and get postcards sent out to a lot of our more rural communities and counties, which was great. We do have these on some of our rack cards, and then we give these out at community events or to providers or anybody who wants them to pass out, so that everyone can have access to our community resources. There are different treatment resources. This is a list of the medication for addiction treatment providers. Most of them are here in Bonneville County. There's one who practices up in Madison County as well. And then we did just get a new clinic in town that's called Ideal Option, and it's also a capital app, and they're a medication for addiction treatment provider agency. And so they're not yet on this list. but they're gonna count. And then these are the county breakdowns. I mentioned earlier that you can go to your pharmacist to get naloxone. If you would go to your pharmacy, these are the pharmacies that carry it and that do currently have it in stock. And then I also have a list of all the drug take back locations in each county. And these are on the website. You have Bonneau County and Clark. There are no pharmacies, but there are prescription drug take back at the sheriff's office. And then Custer, there are a couple pharmacies that have naloxone and a couple prescription drug take back locations. Fremont, for Jefferson, Lehigh, Madison, and Teton. So we have information on all of the counties and where you can go to properly dispose of your prescription medications, as well as to get naloxone if you needed it. And then before I end, I just wanted to show everyone these. So these are our overdose rescue kits. We were able to fund 210 of them, and right now we have 191 of them placed all throughout different areas. So a lot of the probation and parole agencies have taken them schools. So West Jefferson, Bonneville, Joint District 93 has them. Clark County has them. Mackey School District, Lehigh School District, South Lehigh School District. So there's a bunch of different school districts that have accepted these, which is great. Some of the counseling agencies in town, different treatment providers, it's just a bunch of different agencies have accepted these, some of our medical providers. So these overdose rescue kits, they talk about the signs and symptoms. That has our little community resource QR code. But we give these out, and then the Department of Health and Welfare will fund the naloxone to go inside of it. But then somebody can put in their naloxone. It has a CPR barrier mask. It has a little booklet. This booklet has English on the front, Spanish on the back. That tells everyone how to administer naloxone. So if somebody saw a situation and they thought it was a drug overdose situation, they could properly respond and know exactly how to. And then we just have these to help seal it so that the agency and organization that has it, they know if it's been tampered with so that they can check the box. Like this box I use for training, so it's open and everything. If you were to open the box and your box was open like this, you wouldn't really want to use it because it may have been tampered with. So that just kind of gives the organizations knowledge and information. I did check, and we do have, so a couple of them are reserved for our offices, but we have 10 left to get throughout the public health district. And then the nice thing is that when we run out of boxes, the state has another box that they send out through the Department of Health and Welfare. It's a little bit different, but it is still an overdose rescue kit. But it's been exciting to be able to place 191 of these around the health district and places in different offices so that people can respond to an overdose situation if it occurs. So, and then I just like to end with the Idaho Suicide Prevention Hotline number. It's a great number to have on your phone. Unfortunately, sometimes opioids are used as a suicide means, and you don't have to be suicidal to call this number. Anyone can call it, so it's just another great option and number to have. Is there any questions?
Great presentation.
Thank you.
Yes, it was very informative and such an important subject these days. And I mean, I assume that this can be some of the funding that we receive on the settlement, can go into helping grow this program and support it. Should be more resources coming to you here in the near future. Question, Dr. Carter?
Any early data on these kits or other interventions in the state that have been successful, that have seemed, that we've heard use of, that have seemed to make a difference in the tsunami?
That's a great question. So we just started placing these kits in June. So we haven't yet done a follow-up, but that's something that we're working on now to go back. And I'm working on going back and following up with the agencies to see. When the Department of Health and Welfare sends out the naloxone, they do have a report form. And then they ask that people are reporting back to them on the overdose, like if it was used as, like if it was been used, and then was the overdose fatal or non-fatal. So that's a really great option that then we hopefully can start collecting all that data. Part of it is you hope that there's not data to report because we don't want overdose deaths, right, or overdose incidents. But when they do happen, then we can collect that data and that information. And then hopefully, I don't know how specific they're collecting, but it would be great if we could see where exactly it is. So if it's a place that we've administered a kit, then we know to respond. And right now, what I'm working on is creating a system so that way we can go back and check with agencies at least once a year, maybe twice or 4 times a year, to make sure that their naloxone is still in the box, that it isn't expired, and that someone hasn't taken it. Because if you have an empty box, it does nothing at all for you, if you don't have the Narcan in it. So great question. We're working on systems, and the Department of Health and Welfare does have some systems in place for tracking the naloxone. So hopefully we can have some data soon. That's really important.
Quick follow-up question. for
Can I
that.
just answer your question, actually? Do you want to explain a little bit about what you're doing with the Falls Fire Department, and there's some of the data that we're trying to gather from that? So I think that was one of the.
Yeah, so right now I've been working with Chief Day, and we are working on a naloxone leave behind program. So when they.
Sorry, Mallory, just some of the actual overdose data that you're gathering.
Oh, from the continuum report?
Yes.
Oh, so Chief Day's given me access to a continuum, which allows me to see the suspected overdoses as well as the naloxone administration that's happening in the area that they serve, which is mostly Bonneville County, but does contain some parts of Jefferson and Bingham. So I just checked it earlier this week, and there was 1 naloxone administration earlier this week, and there were 4 suspected overdose calls. And so I can go on there and check with them and see, which is great information to have from the overdoses. And then they do have information, so like on this past year, we were able to go back and see what times of day are these overdoses happening? Where are they happening? Different places in the community, and is there kind of a relationship with that? The demographics of sex or gender of the individuals who are overdosing. So we do have that opportunity with them, which is great.
Yeah, so with further to that, like this is kind of a newer program, so that will help us collect baseline, but I think some of that is important to collect. How are we doing on overall overdoses? Are some of these programs actually beneficial? So we need to get more than just Chief Day and Iowa Falls, but we need to get more, first responders into that system would be great. So we can kind of have a baseline and see in more real time the impact.
There is a program called ODMAP, and right now I believe it's in Public Health District 1 that they've implemented it in quite a few of their different agencies. But what that does is it actually pulls the reports from first responders to a system that allows everyone to see kind of real time the overdose deaths, fatalities, suspected overdoses, that information for their health district. And so hopefully that's something that we can get here, and I think it would be wonderful to have across the state. So that way everyone's doing it. And the nice thing with that is that the ODMAP platform is actually free. So it's just contracting to get the data pulled over and making sure that the agencies have a platform that information can be pulled from. But that's a really great step going forward, that Public Health District 1 is doing that. Then hopefully we can gain this information from them on how they did it. And I talked with a lot of our first responders, and they have been receptive and said that they would be willing to do this if we have the opportunity to, which would also be great. Did you have another question?
Just last question. Any sense, I know the data is only in for 2020. What's your sense for 2021?
So they have
Oh,
talked
no.
about a lot of increases, especially because of your synthetic opioids and how many opioids that the DEA is confiscating. So I'm hoping it doesn't rise, but there is a huge chance that it does because of the synthetics, your fentanyl that are out there. I don't know if you guys have looked on the news, but there's a lot of different news articles that have been happening almost every single week of different arrests that they've made where people do have different substances on them that do include things like your fentanyl. And so just knowing that it's here in this community, I would expect to see some sort of rise, even though I hope it doesn't happen. But it has been on the trend upwards since 2018 to 2019 to 2020. We've seen an increase.
Is there no Narcan then?
No, it's very short lived. The half-life is really short in the body, so no, it's very safe.
And then the other thing I was wondering is how expensive is it?
So it just depends. The intramuscular is a little bit cheaper. That can be about like $13 or so a vial. The intranasal, the naloxone, can be about $100 or more for box that has 2 doses. So that's why it's great that the Department of Health and Welfare is funding it. So for a lot of our law enforcement, making sure that that's covered, or EMS agencies, especially the rural EMS agencies. We've worked a lot with them, like up in Hammond and places, so that their quick response units have it, so they don't have to pay the $100. I mean, if you're buying more than 1 box of Narcan, because you have 20 guys that you need to have each of them. So it can be quite costly. So that's why it's great that we do have that.
Commissioner Matson had a comment.
Oh, go ahead, Commissioner Mattson. Yeah, I'm sure you have experience with this.
Yes, I was just gonna comment. I really don't have a question, but just recently we've had more of an influx of the fentanyl, and we've had some fentanyl deaths. So, but in regards to the job that I do in law enforcement, we're seeing now when we're doing our search warrants or our stings or drug busts, whatever you want to call them, that we're actually seeing that they are carrying Narcan with them. So that was kind of an interesting thing. And I think with us letting them know this is what happens, this is what works when you see your friend or whatever overdosing. I mean, at least they're getting it in their hands to maybe help prevent that.
Yeah, great comment. Thank you. Other questions or comments? Thank you. Very important. Thanks for what you're doing here.
If you would take a minute to fill out the evaluation, Mallory would appreciate that. And you can just leave it when we're done at the end of the meeting.
And if anybody wants one of these or multiple, I'd be happy to get them at the end of the meetings to distribute.
Is anyone interested?
I'll take one. Non-clinical spot.
The rescue box, is that what you're talking?
Okay. Rescue box.
I think they're great, but I don't think I need one. I'd rather somebody else, I think, probably needs to get one. So, but thanks, Rob.
Yes, and at any time you can send somebody here, even if they just come up to the front, they don't have to tell us their name or why they're coming or who sent them. If they feel like they need one of these or one of these, they're welcome at any time. And we do have them at our other locations, Eastern Iowa Public Publications. That way, if they're in Rexburg, they can go up to the Rexburg one and pick up a box or a couch.
Is there a rescue box like in the Madison County Courthouse?
I don't have one in the courthouse, but I'd be happy to work on getting one there. I have given one to the Madison County Juvenile Probation, which is just, Kirk and Monty, which is really close. But I'd be happy to work with the courthouse and get one there.
With the courts and them coming to the magistrates and sometimes it's a fairly rough crowd coming through there.
Any art agency who wants one, I'd be happy to work with them. And even if we run out, as I mentioned, the state has some, so I could help get the state ones, and we could even sticker them with our community resource sticker to make sure that people have access to that, even though it's not our fault.
I'll check on and get back to you.
Okay, we'll go to the next item on our agenda then. Unless you have something in between, Gary, so that'd be back to Amy.
So we've just been looking at the impact of the pandemic on clinical services here at the health department. Pandemics aren't new. There's the last 100 years, COVID is the 5th pandemic. I think most people, when they think about pandemics, go all the way back to the 1918, 19 influenza. There's called Spanish flu frequently. They vary in who they target. Spanish flu, high mortality in that 20 to 40 year age population. And then even as recent as the H1N1 that a lot of us were part of, it was interesting to look at that data from 10 years ago. A third of the people over 60 years of age had some antibodies to that H1N1. I was actually surprised looking at the data now that how few the deaths were compared to COVID now. But 80% of the mortality or the deaths were in individuals younger than 65. And so it was a completely different picture. You know, we had long lines, but it was long lines of children wanting to be vaccinated versus what we're seeing in this current pandemic. But it originally had targeted that older generation. So the pandemics are not new. From that, though, we see this term called health debt. It's an accumulation of the impact of health changes and behaviors during a pandemic and the long-term effect of that. So that can be lots of things. So, delayed or missed preventative screening. We've seen this especially early on. Treatment of maybe current existing diseases, chronic disease management, and then just other changes in behavior. Maybe why people are home, increase alcohol, drug abuse, all those type of things. And it's a health debt, it's a debt that we have to. And so looking at, I don't have a. So this is nationally in the United States. This is the percent changes, and you can go on and pull lots of different data. So I was looking at some of the services that we provide here. And so everybody will remember March. I don't think it doesn't forget that. But so childhood immunizations, when that pandemic hit, a huge decrease in those visits nationally. And then over the next several months, you see that do come back up. And some of these I think are around like influenza season, right? People were probably coming to get flu shots and they probably updated them on their routine vaccinations. But this big loop here, that never really comes back up at the same percentages. Other one that I pulled was just screening mammograms. So screening for breast cancer in women. Same picture, and actually even worse, a huge decrease. And same thing, I think there was a little bit here, probably around breast cancer awareness, but still never at the same level. It never comes back up. The National Association of Chronic Disease Directors Survey, they did a survey nationally throughout all of 2021. So Idaho also had, they actually had 4 waves. Idaho had 3 waves of study throughout. These were those reports. 24 to 31% of participants reported worse diet habits during COVID-19. I would be one of those. 38 to 45 also reported worse exercise. The lower number was later in the survey. So early in the pandemic, the rates were worse. So this 31% was earlier in the year versus 24% being later in the year. And so things did improve, but probably not back again to where they were pre-COVID. And again, this was in 2021. And so looking at our visits, this might be harder to see. So these are childhood visits. And we didn't see a huge drop in March. So this is 2019, then the green is 2020, and then 2021. So 2020, when it first started, we really felt that seeing the impact here in April. And I went back in March, some of the end of the weeks went down. And April for us, April and May is huge for back to school registration, kindergarten registration. Well, when that hit, we just didn't do it. We weren't in school providing those vaccines. I talking to a lot of our BSC, our vaccine for children providers, same thing, they weren't seeing those kids in there. Now 2021, we got back into a few schools, but again, we've never at the level we were in 2019. June and July were never very busy anyway, so I think there's a little bit of an anomaly there. And then August is our second where we do a lot of childhood kids back to school, because now they've missed this deadline, right? So now they got to hurry to get in before they do. And so August, we're typically seeing a lot. And so that was decreased by several hundred. It's hard because these numbers are bigger. And then this past year, we did see an increase in there. In the fall, flu always throws us, it depends on when we get through the vaccine, when we're administering it. That first year it hit, we did give some increased flu. That's what these numbers were attributed to. But this last year, it's kind of leveled out. We haven't done as much flu as last year. and not that big push back to school registration. We do, for the first time that I can remember, we had 2 schools that we're going to this month for school shots, which is unusual. We don't typically do that in January. So they're doing teachers, families, and staff for influenza, and then anybody that wants to be caught back up. So I think schools are starting to recognize those childhood immunizations. We're behind because they have to fill out reports. So an unusual request to provide a school clinic in January for us. And then adult immunizations, and I'll break this down to a couple separate immunizations, because same thing, this big flu number makes these smaller numbers harder to see. Same thing though with adult routines, we really didn't see that drop until April. March wasn't as impactful. And then in the fall, when we do flu, we actually, for adults up until this year, and I think this has to do with booster doses. We're giving lots of booster doses, so we're giving lots of influenza at the same time with booster doses. We different from children, we didn't give as much influenza vaccine in adults. So I don't know what motivated parents to bring their kids in for flu vaccine, but maybe not as many adults. But still a drop. And then I brought it down to separate vaccines, a couple of them just to look at. Next slide, Jerry. Yeah, tetanus. So tetanus for here at the health department is a great indicator of an adult routine vaccine. If they come in for anything, we always catch them up on their tetanus vaccine as well. And so the top blue line is 2019 prior in there. So this green is our 2020. You see a dramatic drop all of 2020. And then this is this past year. In the blue, we've never got back up to that routine adult vaccine. Outside of influenza, we're catching some up. But routine vaccines, we haven't rebounded up to here. And then the biggest one, Jerry, next slide down, is foreign travel, which makes sense, right? That makes sense that our foreign travel vaccines will drop off. And we do a lot. So it's same thing, 2019, we do a lot in the springtime. People are ready for foreign travel. We always kick up in the summertime, and then December people get bored and want to be out of the winter, and so they travel. So that's those ups and downs are normal in our foreign travel. So that green line again, 2020, dramatic drop. In fact, we didn't hardly get any foreign travel. December, people must have got tired and decided they wanted to do some. The most interesting though, the foreign travel is the one that's come as close to rebounding pre-pandemic. I think a lot of that is because when they travel, they're required to have some of these vaccines. This one's typhoid specifically. So it's as close to anything rebounding that we've done in the immunization world. Next slide is yellow fever. So I did the same thing with yellow fever. It was even more drastic, that drop. And then it's kind of following that same pattern, right? So people are traveling here. And then actually the end of last year, we're close on yellow fever, giving what I gave 2 years ago in December. So that's IMS. Reproductive health, we actually, when I look at the 3 years, they're within 150 visits every year the same. It stayed very stable. Positive test results for sexually transmitted diseases have been increased, and I'll share that a little bit more of that. At least it felt like it increased. And then early in the pandemic, we did run into some issues with STD testing supplies. All the resources were being moved to COVID, so they had enough resources for testing supplies, but we had a hard time getting our hands on it for just our routine STD testing, and even some of them for our pap smear stuff. So we were having to scramble to different vendors. That's kind of been alleviated lately, but I was surprised the impact that had on us early. And then our local lab, the same thing still continues to happen. Every time they're overwhelmed, they kick our labs out. They outsource it. They outsource our STDs, our PAPs to other labs, and that just gives us results in delay. So now we're delayed in treatment, delayed in notifying individuals. So that's been the impact more than the actual number of people coming into our facility. In 2019, it was reported, that STDs reached an all-time high for the 6th consecutive year. This is old data, 2019. But significant increases in that, 90% for chlamydia, up to genital syphilis, so babies born with syphilis, which we almost rarely see at all, was up to almost 2,000 cases. There is no data that I can find for 2020 or 2021 yet, and I think same thing, impact of COVID has got them behind reporting that data. That next slide, Julie, can't remember this. So it's hard to tell. I have some of our data as well. And you could use this slide for every communicable disease out there. I think we said that COVID as well, right? It's always the tip of the iceberg. What I know, there's so much more that I don't know. And I think that's the case for STDs, especially right now. So I try to get Idaho data, and they also don't have any data for 2020 and 2021. So I tried to pull our data, because staff kept saying, well, I just feel like we're seeing a lot more. I looked at our chlamydia. It would take a long time to add all that up, but I think we're going to be under 600 range for chlamydias. So I looked at some of the smaller ones. They're preliminary because the state hasn't approved them, but for 2019, we had 43 cases in Eastern Idaho Public Health District. So those are cases we diagnosed or providers have reported to us. In 2020, we have 110. This last year, 94. So that's a substantial increase in gonorrhea. HIV, same thing. I went to put 2019. Well, we didn't have any new cases reported to us in 2019. 2020, though, 8, and 2021, 6. I didn't put it in this slide, but these are just new cases. So these are cases of individuals that weren't previously diagnosed. We're also seeing an increase of people that are coming for case management services that are coming from other states that are already diagnosed. And I didn't put those into them, but that's also an intriguing number to me. I want to look more into that are just coming from other states coming to us as well. So, so conclusions, both routine childhood immunization visits have been down the last 2 years. Foreign travel substantially went down, but it does seem to be rebounding. Although reproductive health and STD visits have remained stable, we definitely are seeing an increase in STDs throughout the district, and I would suspect in the state and nationally as well. So bottom line is, what are we going to do about it, right? So immunizations, we are keeping the strike teams that we have going. We've always done a lot of school-based clinics, but now we're adding to workplace clinics. This month we have a couple more influenza ones, but we're going to an EMS station to update their Tdap's, their Hep B's, and a couple other vaccines as well. So we're going to really try and make it easy for people to have access to immunizations. We normally do an annual free immunization clinic. This year we did one quarterly for kids, and we did 2 for adults. So we're again looking for some funding to be able to do that more often. We're pulling every report we can through our EMR vendor, through the state registry, making individual phone calls just to try and call people to get them scheduled to come back in, mailing postcards out. And then we currently are doing provider education, so we're putting packets together for providers that target specific education for maybe their patients that they're seeing. An OBGYN or Tdap for pregnant women, those type of things. And if they're not providing vaccine, then where they can get that vaccine. And we also do a newsletter right now for VFC providers. So for vaccine for children providers that do childhood vaccines, we're looking to maybe expand that out to other providers as well. And then same thing, our immunization coalition hasn't been functioning for a couple of years, but we're reactivating that as well. Yeah. So reproductive health. A couple new things there. So we have started a telehealth policy. I don't have that completely in place. Throughout the pandemic, we would still see people with symptoms. If it was an emergency, sometimes that might be in their car or a provider in an N95 mask, but we did try to accommodate for we are going to be partnering through the state with Let's Get Checked. So currently you can go on Let's Get Checked and you can actually order in-home STD testing. So it's a finger poke and a urine that you send in. We're actually going to partner with the state. Those currently cost where that testing will be free. And then we can provide some of that counseling or treatment through our agency. So we're excited about that. It'll probably be February or March. And then February, I think, 4, we are starting a SGE coalition here with some movers, shakers, some champions in our community, just to try develop maybe some goals and some missions to see if there's maybe some groups we can be targeting, or if there's ways to get that education out, or how to even identify where the needs are in our community. So that first meeting, we'll know more what that mission looks like with that group. But excited about that. And then, 2020, we just want to put it over open. I'm sure like every other provider in here. And the last thing we want to see is another communicable disease like measles, something that's very preventable that people just aren't accessing care, to now be what 2020 is. That's it.
Questions, comments? It's concerning how soon it's coming back, some of those things, that's surprising.
And the more we look into it, I was too, because I didn't know, we didn't have numbers to it yet, so it has been to us as well, especially some of the cancer screening, mammography, pap smears, those things that early intervention can prevent a lot of things. So.
I wonder if some of our legislators wouldn't, this is good information for them, it would be received, right? I assume you could make this available to us.
Oh, yeah.
These slides.
It's on the website now for everyone.
Oh, it is on your website? Great, thank you.
That's part of the meeting packet.
Oh, okay. Okay, we'll go then the next part.
And I suspect this will take us close to 3 o'clock, this next session, so.
Okay. So we'll go ahead and go with our, yep.
James, you can sit here.
That's true.
So normally, when we kind of do presentations, I like to walk around, more of a walker and talker. So this is a little bit hard to stand just in one space with the camera. So we're here to talk about preparedness. We've talked a lot about preparedness and kind of the fringes over the last few years as we've gone through COVID-19, but we wanted to have a little bit more of a formal discussion on what preparedness is, what our preparedness program is, where it came about. We have the preparedness team that kind of joined. I'll just point out Troy Nelson. You probably recognized before. You can raise your hand, Troy. He's our preparedness program manager, and then Mike Weingartner is our planner in the preparedness program, and we'll kind of go over what these titles mean just a little bit. And then because we like to continue the trend, Mike, it's really confusing in meetings, but Mike Taylor, who's a longtime employee of public health, is in the last few years has done the training position in the preparedness program. So the preparedness program, and those three are here to help me fill in the gaps. And you guys can move up a little bit if you want, so we can see a little bit more. Their help to fill in the gaps and to help facilitate the conversation a little bit. They're really the preparedness program began in earnest after 9/11, where it was recognized that there was a need for preparing local communities for disasters, whether natural or man-made. Due to that, we started receiving funding, and Jerry and Troy have more of a history on this, but though that has evolved over the years, what the funding and the contract or the scope of work that goes along with that funding, it's certainly evolved. It was instrumental during the H1N1 flu response in 2009 and 10, but it's evolved. The hospital preparedness program that we've previously done here at Eastern Iowa Public Health, and that we relinquished last year, was also kind of a joint venture or a joint program along with the preparedness program. I'll just point out, much of this conversation is going to be, or much of this, discussion that we have today is going to be really regarding the direction that we're taking the preparedness program. Throughout these last few years, we've learned a lot through the pandemic in the preparedness program. Some we were thinking heading into it, and it crystallized when the pandemic hit and what we were able to do, and some of it we certainly learned from. It also has to do with some of those changing requirements or those scopes of work that they're bringing forward as we go through this preparedness program, and what they're wanting us to do, or desire for us to do, and what at a local level we feel is responsible for what's our responsibility. So really the hope is to clarify the role of the EIPH moving forward. That's the goal at the end of this hour and a half, is for you to feel comfortable with the role of the EIPH moving forward. In turn, I think it will have a lot of maybe some good discussion about where preparedness is at a community level, because that's our ultimate goal. Our preparedness program is just one aspect of the overall. Your county emergency managers, or that are in each of your counties, have a large role in this. That's really what we control at a local level. There's some frustrations that we probably all have with more of a state level or even a national level through FEMA, IDHW, or Idaho Office of Emergency Management on a state level. And we'll call those out here, in all honesty, because I think it's important to know what we can control and what we're going to work on going forward, and what we just will continue to help inform our state partners and our federal partners, but what we may not be able to control as much. But how we're doing that. So really at the end, I want you to feel comfortable taking it to your other county commissioners and, gaining that traction on the role of what East Iowa Public Health is doing. Not only our team, but as I'm looking across at Dr. Gardner, I think during even his interview process mentioned his preparedness acumen, I'll say, and not only that, but his desire to help in that arena, and I'll rely on him during this discussion as well. So some of these, again, we're going to go through the changes in our thought process and really gain some clarity on what the roles would like to be. I'm going to reach out to my team right now. Was there any discussion that we've had that we need to highlight more than what I've introduced?
I don't think so. I think we just carry on.
Okay. Step over with my water. Okay, so we put together two documents, but the first page that we handed out, did you get?
Yeah,
Okay.
I got it.
Perfect. The first one is really kind of just a way to understand the basic concept of what, or the language around preparedness. It can sometimes get really difficult. And as I took over this program a few years ago, I sat in my first meeting and I was like, I don't know what that acronym means. I think they just talk in acronyms, period. They spell out a whole bunch of letters and expect you to follow along. So we're not going to use those same acronyms today, but there is some definitions and vocabulary that are important to know. One, it's centered around this concept that throughout, whether you're talking to a county emergency manager or you're talking to a state individual, that they want to have the same verbiage or the same lingo so that we can all talk apples to apples, so to speak. So this is that effort to do so. Not that it's perfect, but it's the effort. The emergency support functions, and we kind of created a little bit of crosswalk to maybe think of it in a different way. In means, and Troy helped do this a little bit, in means, ways, and ends, right? You may all be familiar with more with that kind of verbiage, but emergency support functions are similar to means, right? It's a way to organize across departments and agencies. These are essential support functions that would like to happen to categorize, and we're going to go through each of those so you have a better understanding. Ways are really what public health. So nested inside some of those support functions, but a completely separate document, are public health responsibilities and capabilities that we're supposed to be working on. So there's emergency support functions, but there's also public health capabilities. Most of the time, those should be nested in somehow into the emergency support functions, but it's not always really apparent, and we're going to try to make it such. And the ends, honestly, are the most important part. This is the intent of any of these programs, right? Is to help provide critical services to a community. And we listed out some of those community critical services and how they're organized and such. But really what we want to do is to help our community be able to respond and help protect their life and their property. So I think it's important, and we all try to do this in whatever we're doing, is to make sure that we internalize that intent as we go through and make sure that that's our end goal. Sometimes we can get caught in the weeds and we miss out on it. So hopefully that's maybe just a helpful document as we go through. Again, please ask any questions as we go through this, because you can get, again, kind of lost, and we don't want that to be happening. So, or this is, our goal is to provide clarity. So again, I'm going to look, any thoughts on that section, guys? What do you want to provide?
Just to reiterate how important it is to have some conversation, because this stuff can be so convoluted, even for someone who lives it day in, day out. It's so beneficial to have good conversation around these things, especially when something is unclear. Just to.
Yeah, no, thank you. Yeah, we learn something when we get together and discuss things, and just like anything else, you'll have an idea that pops in, it's beneficial for the group. So, thanks, Mike. Okay, I'll just say this is a long 16 pages, and I know it's after lunch and all that. So, you know, Sharon, if you need to stop me at any time, please do. But we're not going to spend all the time in the world on ones that on the emergency support functions that we don't necessarily have a part on. I want to go through them so that, again, that you can provide clarity, and hope that you can, as you go through other meetings in your with commissioners or with your county emergency managers, these topics may come up. You may have ideas that come up during this that, oh, I should probably check with our county emergency manager what we do. We'll try to answer those questions along the way as well. Also, I want to go through each of them to make sure that you understand why we may not have a role, right? It's important for you to understand where we do have a role, but also in the areas where we may not have a role. So that's why we're going to go through some of these. We've provided a handout, not just the screen, for the fact that you can take it back and really go through it. I don't expect you to remember all of this at 1 hour and a half long. Sit down. So, emergency support function 1 is transportation. And I'll tell you, this is based off of the Idaho manual, right, Troy? It is. Okay, so why don't you talk a little bit just about the Idaho manual for a minute?
Yeah, so the definitions that you've got for the ESS and your paper that come from the Idaho Emergency Operations Plan, they are generally very similar to what you're going to have in your own county emergency operations plans. Sometimes they are termed just a little bit differently in the counties, but the main concept is the same in each one of them. So as we go through this document, this is set at a state level. Keep in mind that, you know, some of the purposes and scopes you can be phrased differently in your county's plans, or they're just being more local.
But overall, overall, they should be very close, depending on when something maybe was updated last, right? So the emergency support function, one, really deals with transportation. And really about providing and coordinating transportation during emergencies. Or I'm going to just pick out, or maybe providing expertise in evaluating the load bearing capacity, or assisting authorities in evacuation operations during an emergency. So again, this is the Idaho state plan. These aren't your specific county plans, but you have a role in that. What that role is determined by what you've agreed to do and what your emergency manager has written to plan. Any thoughts, Troy?
No, I would just say that it's important to go back and review those county emergency operations plans. Some of them are a little bit older than other ones. Like I said, we've tried to go through the ones that we can get. And we can have that review them.
So this one, we don't have a role in. And I know you're like, well, that feels like common sense. There's going to be some scenarios later on that maybe feel like common sense to us sitting in this room that public health may not have a role in, but yeah, we may be being asked. So we'll go through this a little bit. I have highlighted some sections as we go through that really have some pertinent questions surrounding them. So again, emergency support function 1, transportation is there to help us get what we need to do, where we need to get. Emergency support function 2, communications. The purpose is really to provide the state, tribal, and local government emergency communication support services. You may all have an idea what this is about. Give me a brief synopsis and then we'll go into what we're doing, Troy.
Yeah, so this one really focuses on the methods that we use to communicate. Some of them you're probably more familiar with. Some of the things we use, the Idaho Resource Tracking System, which probably you're familiar with after going through the whole COVID experience. All the hospitals, nursing facilities, places like that, go onto this Idaho database. They fill out all the different information about what type of patients are seeing, whether or not they've been vaccinated, those types of questions. We use that to track the hospital's capabilities, where they're at, how much they are struggling, how high their census is. We use the Health Alert Network to push out messages to pharmacies, to doctor's offices, very quickly on events that are happening quickly. Maybe you see one you're familiar with, the CAT machines, the health district uses so we can communicate, so we can provide as near real time as possible updates on events that are unfolding. Other things, Twitter, Facebook, those are all communication platforms. And that's what ESF2 is really all about.
Yeah, it's about the platforms we use. I'll just say, and kind of reiterate from before, we learned a lot during the last 2 years during this pandemic. One thing we learned is, and I'll just say this is a general concept, previous to this, we have a large plan that we put in place, right? It's substantial, about from pandemic influenza to name 5 others, Troy, real quick for me.
Smallpox, anthrax, SARS.
Yeah. We spent a lot of time putting together these plans. Most of those plans, I will say, had to deal with kind of an acute or very short-term scenario. This pandemic has kind of thrown that on its end because it's been such a long plan. That's the first thing we learned, right? We need to, we had that in the back of our mind, but we didn't really fully experience it. We've experienced something now. And it would be a shame if we don't use this thing as a preparation for something more serious. And that's really why we're reviewing this and going through it. We need to be more prepared in our own realm. So,
One quick comment to add to that we've learned this last year. We've also never planned for every jurisdiction in every corner of the country and every part of the world to be affected at the exact same time. And the subsequent supply chain effects and resource shortages, both manpower and supply. And so that's been a good test. It's a lot to learn from that.
And I'll just tell you, if we don't take lessons learned from this, we could be in a very bad position if something does come that's more drastic. The COVID-19, I'm not trying to reduce its impact on our society and on individuals, but there's much worse things that could happen out there, and we need to be prepared. So I'll just explain. I don't know actually if all of you know what Web EOC is. It's a platform that we can kind of communicate. It wasn't utilized as much. It's fairly antiquated. We need to improve on that. The Health Alert Network messaging, and I don't mean to point you out, Dr. Gardner, but you receive our on messages.
I do.
Yeah, and he's the aberration, I would say, probably, because it is.
Is that a nice way to say it, Howard?
Yeah. We send out emails and faxes to multiple providers and clinics regarding important messaging. I don't know how far that gets down to the end of the road. We've done exercises on it, hey, send us back something in preparation, for the last 10 years, not just during this time, about, hey, we sent out a HON, please kind of let us gauge our system. There's nothing like the real experience to notify us of that. We need to improve our Health Alert Network messaging. That's not just on us. I will say we need to do our part, but it's also on the providers. We try to do a good, in times of peace, I will call that, we try to do a good job of not trying to just inundate monthly sending out something so that it's just a delete thing. But we've certainly done, I don't know, a dozen in the last 6 months, Mike, I would say. He's in charge of our, I don't know how much that water is getting to the end of the road. And I suspect not as much as I'd like, because I get the same questions from providers that I just sent out in a Health Alert Network message. So
I'll just add one thing to that, James. We talk about it with providers all the time, and without a doubt, every time we talk to different providers, it's like it's a new system and they've never heard of it before.
Yeah.
And there's constant turnover within clinics and offices, and it's a never-ending thing, and the system is a little bit antiquated, although it does send out text messages now, which are nice, but there are other options out there that
and we certainly want to improve on that system. One thing I'll just say, that if I might use Commissioner Mendenhall's earlier comment on our employee policy about please update your email, it probably needs to be something strong. Like if it's just a please, we don't know, it doesn't get done. So, and maybe there's probably a better system, but we're a little bit tied to HON through some of the state and some of these other things. But it's one of the things that we're going to try to push back to our other partners and say, hey, this is antiquated. We need to get better and faster and a better ability to see who opens these things and what the click rate is. So, okay, so Public Works and Engineering is the emergency support function 3. Again, we do not have a large role in that. You might think, well, does environmental health have a response role in some of these things? You'll see where they come into play. They are heavily involved in many aspects of responding to different disasters. We'll get to that. I apologize, Commissioner Madsen, if I haven't continued the paper on the computer. So again, I think coordinating needs of damage assessments following a disaster emergency or providing emergency power to public facilities are some of the scopes or high-level scopes inside this area. Firefighting, we won't go into much detail. It's fairly self-explanatory. I think we know what that is. Public health does not have a role in either the public works or firefighting role. Emergency support function 5, emergency management. Troy, tell me what, I thought that's what we were talking about, emergency management. Why is this a support, an emergency support function as well?
So this one really just, it tries to emphasize the fact that across all the state agencies, across all the local jurisdictions, the emergency management is important. It tries to list out all the different things that the different agencies need to do to work together to provide an effective and an efficient response to an event. And this is one of the first ones where we really become involved.
Yeah, so here's where we start to diverge just slightly from our, or going further into the public health response capability. We did it slightly earlier on that web EOC section where we needed to also have platforms. But this is again, so nestled into this or in addition to that emergency support function, this is where our response capability number 3 stands out. And this is where we're going to spend a little bit more time as we go forward. Some of these blocks that we sectioned out here. Emergency operations coordination is the ability to coordinate with emergency management and to direct and support an incident or event with public health or healthcare implications by establishing a standardized scalable system of oversight, organization, and supervision that is consistent with jurisdictional standards and practices in the National Incident Management System. I'll just say the National Incident Management System, in a brief overview, is just another organization tool. I think county commissioners do have to take the training. Is that correct on like an incident command structure 100 level?
It's offered.
It's offered.
Just not required.
Okay. So that's kind of the National Incident Management System, right? Or one aspect of it. So again, thinking of how you scale things, that's certainly part of it. I've highlighted healthcare implications here, and this is going to be an ongoing trend throughout this document, as well as what I referenced earlier in the healthcare preparedness program. The healthcare preparedness program really turned into, I'm going to look to Troy to give a few examples here in just a moment, but doing things to prepare hospitals to respond is the name implies, hospital preparedness program. And they were giving that through public health to try to help lead that effort. Well, in reality, I can't tell ERMAC what to do. I can hopefully educate them and I can do these things, but it's very difficult to tell ERMAC or Idaho Falls Community Hospital. I'm not trying to single one out in any way, but what they need to do. Do I feel that it's important for our community? Absolutely. Can I tell them what to do and how to best prepare for that? No, I can't. Troy, would you mind giving just a few examples of what was in the hospital preparedness program that we started giving?
When the program itself started out, it was, the contract was written very generically. They give a lot of freedom to work with pretty much any first responder agency in the community. And you know, how you define that was very broad. It included EMS, firefighters, schools, really anybody that you could think of that had some type of emergency response on a community basis. And it was all supposed to be centered around the healthcare system. As the program started out, you know, over the years, we ran that program for probably 18 years. Funneled millions of dollars into your communities in assets, in training, in education. I think the great big generators that used to power hospitals, the evacuation slides for hospitals, jump kits that went to EMS facilities. It was just a fantastic program. But as the program evolved, Congress really wanted stricter oversight on where that money was going. And so they started to become much more specific on, you know, what those type of deliverables would be in that, to the point where the contract itself became very, very hospital centered. Things that only realistically only a hospital could deliver. And the problem we ran into with this BC Health District was being held accountable for the delivery of those products by a hospital. We can't enforce that. We have absolutely no way to ensure, to make sure that happens. So that was really ultimately the demise of that program. For us anyways, it became so centered around hospitals that we finally felt like this program needs to be run by a healthcare facility. That's really where the contract is heading, and that's where it's going.
And rightly so. I don't begrudge maybe some more oversight and make sure that the intent of helping to provide for these things is in a disaster are utilized, but we also have to be capable of actually making that water get to the end of the road. We can't, that's going to be concerning, and that's what you're gonna hear over the course of this. I also want this, I want to be clear here as we go through this a little bit. We're not looking to advocate our role in any sort of fashion. What I'd really like to do is more fully focus on where we do have a capability and where we do have a responsibility, and make sure we do that to the best of our ability. I think too often, we sometimes talk in generalities, and we think when the pandemic or the disaster hits that we'll all kind of figure it out on the fly. What we know is if you're not doing this on a regular basis, when a disaster hits, you're not going to do it in that time of disaster. Mike.
And not only if you're not practicing it beforehand, if you don't know which entity or agency is the responsible party prior to, you won't have enough time to figure it out.
So really, we're looking for clarity of roles, not just with us, but others as well, about whose responsibility is it. We don't want to give any false pretenses that public health is responsible for some of these items, when in actuality, we can't do that. Either due to, I don't want to say an ability, because we need to increase our ability and we'll get there on the things that we're responsible for. But if we don't have the statutes backing us up from a legal standpoint, or our board support that, or if we just don't do that in public health in Idaho, we need to really look at that and make sure someone's going to do it, but that can't necessarily fall to public health, because when the disaster comes again, it will be problematic. So again, so that's what brings up this highlighted healthcare implications. All healthcare implications are not the responsibility of public health. And we know that. The functions would further break down this capability. Yes, we're happy to do. We're happy to conduct assessments, on the need for activation of public health emergency operations, and do those emergency operations, and then, at some point maintain and sustain, and then evaluate it. We're doing that right now currently with both my epidemiological functions, with Amy's immunizations functions, as well as our preparedness team getting vaccines and other material out to the community. But again, all healthcare may not be the responsibility of public health. Okay, again, we'll talk more in detail here coming up, because that's kind of that emergency support function 5 is kind of like a little overview section almost, right? It's an interesting one. But. So emergency support function 6, mass care, emergency assistant, housing, and human services. Mike Weingart, you want to just talk about that just for a moment, or just read through that a little bit?
Sure. The
purpose and scope. Yeah.
Sure. Monitors and coordinates state support for mass care, emergency assistance, and housing and human services. Scope. So Idaho emergency support function 6 includes activities associated with the primary functions of mass care, emergency assistance, housing, and human services. So there's not a whole lot that we can say public health would have a role in. We did talk about this
yesterday, and this was a thought that came to my mind, ongoing WIC support during this period of time.
Yeah, and certainly they may have a role in that, yeah. Especially on that. So further in the public health capabilities in the mass care, outside of maybe that WIC, which is a good component for one of the components. Mass care is the ability of the public health agencies to coordinate with and support partner agencies to address within a congregate location, the public health, healthcare, mental, behavioral health, and human services needs of those impacted by the incident. I think we're all willing to support partner agencies as they do that. I'm going to give actually some, I think it's important to kind of look down here at the EIPH capabilities, so you can kind of see what we think are our roles within that, and why we might be concerned about some of that language. But really, the environmental health response team, and again, we use kind of response teams, or we're starting to use that language just because, you know, Amy's responding in one way, and environmental health might be responding, WIC might be responding. So environmental health's really to conduct environmental health assessments of the shelters and provide food inspections, right? If they're serving food, we want to make sure that food is appropriate to the guidelines that environmental health is set up. The epidemiology response team, if there's an outbreak of a GI illness or other reportable disease, certainly we want to conduct and help with that health surveillance for those needs. And then Mike made a good point and a good evaluation of the WIC program activities for clients at that shelter, at those shelters, especially if it's a little longer term. They're needing some staples of food, maybe WIC can help out in that arena, especially for those individuals. Where it's difficult for public health, I'll just say, and within us, is to really to look at all healthcare or mental behavioral health. We don't have that capability, and all human services. Sometimes when it starts to blend into those other areas, it's very easy to start thinking, well, I saw on response capability number 7 that public health is going to be taking care of behavioral health, and that's just not the case. It's not within our expertise. It's not within what we do, and it's certainly not something we've done before. So in this time of a disaster, if there's a mass care that comes up, including, I'll just say function 2 is very concerning, determining mass care health needs of the impacted population. I don't know the first thing about determining behavioral health needs of individuals other than any of the rest of us in this room. I think we all might know it when we see it, but that would be, we should leave that up to the experts in behavioral health.
Just to support your comments, we do work with community members throughout the district to ensure there are behavioral health assets available. It's just not something that public health is responsible for. And in the plan, which I'm responsible for, I would reference out to those parties that we've been in communication with so that they understand their roles and responsibilities, as well as the mesh point for when they become involved.
So let me jump in there too. This is one of the places where we're really starting to have to push back against some of the directives of Idaho Department of Health and Welfare and even the Centers for Disease Control and the language that they've written into the capabilities. 3 places in particular, some of the language references that public health is responsible for ensuring that hospitals have alternate care centers, alternate care sites, places that they can evacuate to take care of patients or something they have in their facility, which sounds wonderful. It's a great idea. How do we do that? How do we enforce it? How do we go to Urban and say, all right, where's your alternate care site? Do you have everything in place that you need to make this function? You know, all the agreements in place. How do we do that? That's not our wheelhouse. The second part where we really run into a struggle here is medical stations, federal medical stations, and then as well medical sites that they've asked us to set up, so we have a medical shelter. We actually, you know, in years past, wrote a plan for how we do medical shelter. The whole statute material right now up in Briggs for that very purpose. And we said this several times over the years. How do we run this as public health? How do we run what is essentially a stripped down hospital? Where's our authority come from? Whose license are we operating in to do that? There's so many unanswered questions there that it's just really outside of our realm. And then the really big step up from that is that they also want us to ensure that we have plans in place to set up medical stations, which are 500 bed, you know, hospitals that they would bring into a disaster setting. And imagine the logistical nightmare surrounding something like that. Again, something that's really outside of our expertise and our as public health.
I think that to Troy's point is it's confusing because if there's an event, let's say Madison County, there's a flood, and we've got to, in short order, provide mass care for 500 people for a few nights. Some of those people have medical needs. We can start making calls and we'll call the university and see if we can use some space and rally. But where are the trailers with the cots? They're here. You know, at least some of them are here. So where are those things? It's here. Who are the people? Who are the only people who've been talking about that? They're here. You know, this isn't a routine conversation. I'm taking a guess here at a meeting of the county officials. This is just not part of the routine. So I think that's confusing when we talk about what does this really mean? What do all the binders, what the plans mean when it hits the ground? And it's the federal government doesn't help clarify this, because when we set up a federal medical station, who does that for the federal government? The public health state. The National Public Health Service are the ones who are activated, and they pull in some NDMS folks, and they're going to set up and help operate one of those federal medical stations. So I think it's a mess.
Yeah, very much so.
It's a big mess. I mean, you got to get the resources to the place they need to be, but I agree. You can't set up a medical station. You know, everywhere else, the hospital can barely staff themselves on a normal day, let alone move people.
So, general question.
Yeah.
Is there somebody telling us that we have to be doing all this stuff or we can't really do it? Is that the point here?
Well, I think this is the start of the conversation a little bit. Is there's some directions from IBHW through our sub-grant that we need to be looking at this. But there's also some alternative pathways that are coming down through the counties, right? IOEM also is very much responsible for this plan and down through the county emergency managers. And we've had discussions with the county's emergency managers. I had one a few, I guess a month ago, and it's ongoing. And we continue to have that. It's somebody's responsibility, and we need to start clarifying some roles. And I think that's what we learned in a nutshell a little bit. It may not be ours, it may not be even something that's feasible. We may not even have the authority, and I think that's where we're concerned about the authority and some of that. I don't want it to go by the wayside either. We need to make sure that the best thing to do in a disaster is to continue to do what you've already been doing on a daily basis, or at least a regular basis before that. That's the only way that, and we all have our part and we elevate together. But if all of a sudden the population looks to public health to come in and set up a 500 bed, or to just do, I'll use a really opportune example, to all of a sudden do testing for COVID for everyone, it's not really reasonable. Two, we're not set up that way, and I think there's other implications to that, right? We don't do that on a regular basis. In an emergency, sadly, if you are not doing it on a regular basis, it's going to be really difficult.
Are you still having weekly or monthly meetings with your emergency managers?
With the county emergency managers, there's an ongoing meeting that they have on a weekly basis with their Idaho Office of Emergency Manager, representative for this area, and they invite us as they meet. So, yeah, and again, we'll go through this. I don't want to look at this that we're advocating certain responsibilities, but I want us to be realistic about what we have the authority to do going forward. So we want to, I think that's really the only way that when the rubber meets the road, we can all be actually ready and prepared. So emergency support function 7, resource and logistics support. This is again not something that we are directly responsible or involved in. It's for state and local governments to respond with logistical and resource support. I'll just say emergency support function 8 is where we spend a lot of there's a lot of capabilities with it. This is where we'll spend most of the time. There's 15 in total, I think, emergency support functions, or 17. We'll spend the next 30 minutes going through this, and the next just a few minutes after that going through the other stuff. So this is an interesting item because in the Idaho plan, I will be honest, ESF, they use ESF 8 or emergency support function 8, both as kind of an emergency support function, and it's termed and titled almost like a person at times. There's certainly work to be done in this arena, and it's a big aspect, and it's something that we think a lot of during disasters will be happening, rightly so. So the scope, I'll just read: assessment of health medical needs, health surveillance, medical care personnel, health medical veterinary equipment, patient evacuation, patient care, safety and security of drugs, biological and medical devices, blood and blood products, food safety and security, agricultural safety and security, medical consultation, behavioral health care, public health, vector control, potable water, wastewater and solid waste, and mass fatality management, victim identification, veterinary and medical support. So again, that's a big list and a large scope. We'll break it down here just as we go through. So our first capability in the public health emergency preparedness and response role is really the community preparedness for the abilities to prepare, withstand, and recover from public health incidents in both the short and long term. So the public health role in community preparedness is to support the development of public health, healthcare, human services, mental behavioral health, and environmental health systems that support community preparedness. Again, this is where we start having a little bit of concerns on, we're happy to do what we can and what we have authority to, but when it starts becoming healthcare, human services, and mental and behavioral health, there's other lead agencies that really should take the lead on this. We're happy to kind of refer our plan to them, but IHW has actually a behavioral health section, right? So we want to avoid duplicating scenarios in this as well. Participate in training, I'm not going to go through all these again. You're happy to look through them, and I encourage you to do so. You can talk with your county emergency managers. But again, highlighting some of the concerns about healthcare and resources that help protect the community's health and address the access and functional needs of at-risk individuals. Certainly, we care about individuals that may have, or at-risk individuals that may need a little bit more concern. If we have to address all of their health concerns, that's something that we're not going to be able to do in a disaster. So what can we do? Again, plan to address the health needs of the population that have been displaced because of incidents that have occurred in their own or distant communities, such as after a radiological or other disaster. So again, if somebody's getting displaced into our area, or they're getting displaced from within our area to a centralized location, I'm not exactly sure how we're going to address all of those health needs. When the toxin absolutes, it's a little concerning. It's a little bit concerning. I think sometimes what is missed in these is when you look through the definitions, I agree that those need to be done and the scopes are really important. When it comes to the functions, it feels like they've left off and become kind of that, hey, please update your email and some of those things. I mean, there's a lot of nebulous out there, and that doesn't do anybody any good by the time something happens. It's a question. Yeah.
So where did this document come from? Is this part of the grant?
Yeah, Troy, you want to take that?
Yes, so the page you're looking at right now, capability on community preparedness, that document was generated by the Centers for Disease Control. They put together what they call their 15 preparedness public health emergency response and preparedness capabilities. It's a federal document.
Now, it's important to know inside that federal document, it does leave some wiggle room, right? And then they in turn pass it to the states, and the states are supposed to kind of help understand and break that apart and make sure that those are all being taken care of, because it's a responsibility as such. The problem is if the state isn't understanding in the same way as local public health, it may be concerning in the fact that if they're saying to strengthen community partnerships to support public health preparedness, yeah, we can do that. We do that on a regular basis. But if it's to plan to address the health needs of the populations, I can't address all the health needs of the population. So it's somewhat language writing and a skill. Okay, this one is a large one. I just highlighted the actual title. It's the public health emergency. It's still emergency support function 8. It's number 8 for the next few pages. But this one is fatality management. So fatality management is the ability to coordinate with partner organizations, agencies to provide fatality management services. The public health agency role in fatality management may include supporting recovery and preservation of remains, identification of the deceased, determination of cause and manner of death, release of remains to an authorized individual, or provision of mental behavioral health assistance for the grieving. This is actually a great example of what you were just asking about, Bill, the maybe include supporting, right? And the state government or IHW sees that and say, oh, we need to do fatality management. It's in the, the CDC document for public health entities. Well, there's that little word about may. I hate those, to be honest, because it leaves that nebulous feeling. I think we can all agree that public health in Idaho does not have a role in recovery and preservation of remains or identification of the deceased. We have elected coroners for this position. So do I think that's important? Again, I'll say yes. Do I think that it's a public health role within Idaho? No. Is it a public health role across the nation anywhere? It very well may be. I don't know each location's. That's kind of the con against the decentralized area. But again, I think it gives the ability to do it, but it's not necessarily our responsibility because we don't have the authority to do it. This is, to me, a perfect example, a very concerning one. So in our plan that we're responsible because of our sub-grant with IHW, it may say something to the fact that coroners within our jurisdiction will do this. That's our role as we see it. We're not going to try to do any more than that.
This is one of the pitfalls of a federal guidance document. This is pushed out to every health department in the nation. there are some health departments in the nation that have corridors in them. They do that. Idaho does not. And, you know, to our benefit here, we went through each of your county emergency operations plans. None of them identified us as a primary or supportive role here, right? And rightly so. We don't have a role.
So going on, capability 8, medical countermeasure dispensing administration. Amy stepped out, but this is a great example. We need to look at medical countermeasures, whether this is a vaccine or an antiviral or an antibiotic, depending on whatever we're trying to fight at the time. But there's two parts to this. One, really, it's the dispensing part to the community. That's really what the preparedness team does. You want to talk about the SNS right now? I know we're talking about it in a minute, but it might be good just to bring it up now.
So the SNS stands for Strategic National Stockpile. And those are caches of assets that are staged around the country. And in a time of need, those assets will be requested and delivered to areas that need them. And we would potentially request what they would call a mission prep pack or a push pack would arrive on a C-130 or something like that. We would take those materials and distribute those from a distribution hub within the district to all of the counties and population that we're responsible for. And we run a similar, much smaller scale currently with the COVID vaccine. We request vaccine assets from the feds through the state. They come to us as a redistribution hub, and we make sure that not only public health, as in Amy's group, has the vaccine they need, but all of the providers in our district who request them, who are going to administer them to the population.
Yeah, so that dispensing is a role for public health to make sure that all the community has access to that medical countermeasure, no matter what it is. The second part of that is the administration. Now, we know that public health can't necessarily administer all the vaccines for the community or antiviral. So that's where we start having partnerships with other medical entities to make sure that they can do that. Maybe even other large employers, right? If we need to get it out. And this was an interesting aspect to the pandemic, this scenario. Previous to this, we've had arrangements with school districts and INL, not to call out one particular, to help in an effort to get a vaccine into as quickly as possible into different across the community, right? And every arm we could. Or is there a spot that we can do that for mass clinics? Now, it's interesting, we've had MOUs in place with different locations. But when we came to exercise those MOUs, those facilities were not always there because especially, I think they would be there in the case of a 72 or a 96-hour event or a 48-hour event. But when you're talking months or longer or weeks or longer, that was difficult. They didn't want to necessarily put their business, and rightly so, on hold. So we have to go back to the drawing board and make sure that those MOUs are not only signed, but they know what the intent of those MOUs are, and that they really know what they're signing the dotted line for. That goes for the same fact that we call pods or point of dispensing or point of vaccinations, depending on which one. Like the hospital would be a pod, and we would just give them the vaccine, and they would do their own employees, maybe even the employees' families. Or INL, we give them that. If those partners aren't actually ready to do that, they should not sign on the dotted line. And they need to look at ways that they can do that. We need to make sure, though, that we have enough community partners to deliver it to the community as quickly as possible. And that will be an ongoing effort and the one that we'll tackle. And have started to tackle, but again, we need to make sure that what they know what they're signing up for.
Just to clarify, so for that example, that's the responsibility of the health department to form those relationships, nurture those relationships, have signed MOUs, and have a plan in place for that very specific health and medical mission associated to the overall disaster. It would be the emergency managers, the county emergency managers, who would have the overall responsibility to coordinate the sheltering operation. That may include us as a, we're gonna screen the diarrheal illness in there, and put our epidemiologist to work and all of that within that. But that's not us that needs to go out and say, hey, you've got a big space here. We want to use this for a shelter if things go south. That's emergency management that does that, and then they wrap us into that medical piece.
Yeah, and I think that's a perfect example of kind of a lead agency versus a supporting agency. This case of the medical material management or strategic national stockpile or medical countermeasure, we're the lead agency. We know that, we're preparing for that. We have the authority to do that, even more importantly. But in the case of a medical sheltering, we might be a small support agency, one of 10 or 15. But we are not responsible.
Because we're still not a response agency per se.
No,
we've talked about this many times. We don't have teams and backpacks and boots to roll out into that's just not our space.
Yeah.
This piece is critically important for what we do is preparedness. If you look at what I consider to be the truly worst case scenario, is smallpox, where you have to administer vaccine to your entire population within 96 hours. Protection. You stray outside of that 96 hours, if the disease is rapidly spreading in the community, you're looking at a 35% fatality rate or something like that. So we've got to be prepared. And we've done the long haul now, but we also have to be prepared to do a very quick turnaround.
Well, then that had to go through the Supreme Court to see if. So.
You are toast.
I don't think we'll have the same problem convincing individuals, maybe. So again, a lot of emergency support function 8, and then the corresponding public health capabilities really have to center around with emergency support function 8, medical countermeasures and dispensing. There's a few other capabilities. Again, we kind of talked about them, medical material management and distribution, but that's the big portion of the emergency support function 8 is what we do with that area. So capability 10, again, this one is similar to the, and Dr. Gardner just spoke on that, and I appreciate it, is a medical surge. Medical surge is the ability to provide adequate medical evaluation and care during events that exceed the limits of the normal medical infrastructure. We have a great example of this. Idaho went into critical crisis standards of care. Thank you. Crisis standards of care. I didn't hear a call to public health to set up a medical surge because it wasn't intuitive to what our process is. Not only that, we really don't have the authority or even in our wildest dreams, the ability to do medical surge for that. So again, assess the nature and the scope of the incident, support activation of medical surge, support jurisdictional medical surge operations, and support demobilization. That one we have a lot of concern regarding. Any thoughts on that across the team or Dr. Gardner? You on this one?
Yeah, I completely agree. I think it's a challenge because well, we don't have a response capability to help with this. We don't have authority to tell hospitals, at least until crisis standards of care type authorities are spoken, yes. But maybe there is a little bit of some responsibility because much to the point earlier with the Health Alert Network, people aren't seeing it. They're not signed up. They're not reading it. It's not enough. It's the same in the hospitals. You know, hospitals are businesses, and their job is to make money, and they're not thinking about how can we do, how can we be prepared to help the public. And that is a bit of little hasty. I don't mean that. There's not good people who aren't thinking through these things, but that's what their day-to-day thoughts are not primarily about this. But that is kind of what our day-to-day thoughts are about this. So maybe while we don't have a specific role in the response and we can't dictate authoritatively during a response, but there probably is some obligation or responsibility, or at least expertise and moral obligation we have to say, look, can we talk about this? Can we sit down with some hospital leaders and talk about the plan and some things that maybe we could talk about preemptively, or how this might look, or how public health could support the frontline health workers in hospitals when something like this happens. But
Yeah,
I don't know.
no, I think that's well pointed out. I think that's going back to one of my earliest comments. I think that's what we're really looking, not only for you to understand the clarity of roles here, but also to engage your county emergency managers and us. I think we all have that responsibility to start engaging on those conversations, to say, hey, public health may not have a medical surge opportunity. Can we start that dialogue now so that maybe the hospitals or healthcare workforce is more prepared when that time comes?
And the crisis standards of care is a very fresh example of this.
Yeah.
It's been a disaster trying to figure out crisis standards of care during the crisis. At the hospital, there's people who are doing this that have never, this is the first they've ever heard of crisis standards of care. And then, blood shortages are coming up, and now we're talking, well, the blood shortage is here. And now trying to talk through that and how we're going to figure this out while we're dealing with staffing shortages and big demands and health departments swamped doing all the things that they've got to do during all of this. And now we've got to pull away for a meeting to talk about this. It's a great example that we should, again, learn from and say, would this be worth a 4-hour meeting with just here, a 4-hour meeting with hospital officials that we lay out and say, here's some things we're worried about. What are you worried about? How can we best coordinate when this goes down? Because it will go down.
Yeah. And I think that's aptly said. We have to strike kind of while the iron is hot, and this is fresh in our mind. That's why we're looking at it. Even kind of in the midst of what we're going through right now, it's still an opportune time to look at this. It's also important. We've had some of these conversations in the past. What we've learned throughout this is it needs to have the correct people in that room. We've had the through the hospital preparedness program, a healthcare coalition with hospitals represented and fire departments represented. But when the pandemic struck, those individuals weren't the individuals that were making any of the decisions. So that correct people need to be in that room to make sure that when they're signing on the dotted line, no, that company will stand behind them. So. Moving on to the capability number 11, non-pharmaceutical interventions. This is one we've lived over the last few years, besides the vaccine. So again, it's right up our alley. It's what we use. Interventions may include isolation, quarantine, social distancing, hygiene, precautionary protective behaviors, and other things. Again, determine, implement, and monitor how those things are going. So I think that one's fairly self-explanatory. And I think we've all lived and done that in the last few years. Response capability number 13, public health surveillance and epidemiological. Again, We support the public health surveillance. We continue to do epidemiological investigations. We analyze those trends. We try to help provide data to inform decision makers in that process. Fairly straightforward and something we have the authority to do, and we strive to do our best ability to do. Again, still continuing with emergency support function 8, capability 14 in the public health emergency preparedness. Responder safety and health, or the ability to protect public health and other emergency responders during pre-deployment, deployment, and post-deployment. This is where it may be difficult for our public health agency to always know about other emergency responders in a disaster and their safety and health. We can do it in those same aspects of maybe some epidemiological investigations, depending on a norovirus outbreak at a Forest Service fire camp, or even a food inspection at a Forest Service fire camp. Some of those things are right up our alley, but to an emergency responders for Idaho Falls Fire Department, not only do we not have the authority to go into the medical records, we don't have that capability. Again, one thing I want to call out here, the food, drugs, and maybe I'll even rely on Kelly here just a little bit. Food, drugs, and medical device safety, ensure the safety and efficacy of regulated foods following a disaster emergency. If necessary, conduct seizure, removal, or destruction of contaminated and unsafe products. FDA ultimately has the authority to confiscate or to seize or destruct of medical device safeties. We don't have that authority whatsoever. I'm not going into somebody's home and pulling out spoiled milk. We don't have that capability unless I'm mistaken. We may have some ability in a restaurant through our food protect, like our food protection program. But again, that when it's outside of our scope or our authority, we start having a little bit of concern when they start putting it. So that is emergency support function 8. I'm going to stop there for just a moment and give time for some questions throughout any of that document.
Questions? There's a lot there. There it is. Well, and I keep thinking how much easier it is if you have buy-in from the public, right? Yeah. I mean, if people will work with you. Makes it hard when sometimes they work against you. Yeah.
And the group, any quasi political or governmental group starts coming in with some of these things, they're going to meet with a lot of resistance in some of these areas.
And that's the difficult part, because there's a balance there, as we've experienced over the last few years, right? Some individuals want
total control.
Yeah, to hand it over to somebody to give them total control, and others don't want any control whatsoever. So there is difficult times in some aspects. I think ultimately that's why I go back to that very first page. Ultimately, we want to do those critical services to help protect everyone. And I think that's where we have to look at. So I'm going to forego the other ones, agriculture and food. They're very similar to what we've gone through. Talks a little bit about what facilities, environmental health may do, but again, has some just quick inspection, detention, and seizure of suspect food. We don't have that authority. And then many of the other ones do not have a public health role. And it calls out some of the same things we talked about earlier. So I'm going to give the last few moments to my team maybe to talk about anything you want to highlight or something that we may have missed during the discussion.
Just before I do have something selfishly regarding the plan, but did we want to talk about the response teams at all within the health district?
Yeah, I'll touch base on that.
So as regarding the plan, it's evolved, continued to evolve, and will continue to evolve. And the concerns that we brought up during these capabilities and support function discussions exist in real time for me every day, in that I am trying to there are obstacles between the requirements from IDHW in drawing up the plan and the realities of responsibilities, authorities, capabilities of Public Health District 7. All the health districts are a little bit unique and they all have different capabilities. We're all being called upon to draw plans for responses to things that are well outside of our scope. And we mentioned fatality management, that's kind of low-hanging fruit. Another low-hanging fruit is CBRN, CBRN response, which is a chemical, biological, explosive, radiological, or nuclear response. We have very, very little to do with anything in a CBRN response. And just to draw that to the attention of the board that these are real time. I am currently developing plans and the state is working toward development of plans that are outside of the scope of public health. And in most of these situations where we find ourselves, I'm referring to plans, agencies, and organizations outside of the department that are responsible for these types of responses. And there's a lot of coordination that goes on with that. There's a lot of education that goes along with that. For the past 10, 15, maybe even 20 years, the fallback has been public health. The catch-all has been public health. All eyes turn to public health in times of need or disaster. And there's a lot of education that has taken place, but needs to continue to take place in order to ensure that all of the agencies are on the same page when the response is needed. So those are my 2 cents regarding the plan as it currently stands and the evolution that we're working towards. And we have evolutions that are due in 3 months. So it's very real.
I think we can just add on for when he says I think that entire team feels that each day that they're, playing this game. So I don't know, Mike or Troy, do you have anything?
I think I'll just finish up with this. It's critically important if and when we finally emerge from COVID, that we capture the lessons we've learned over the last 2 years. And that we write that stuff down and we go back and we change each of our lives. Not just counties and health department, but giving us fire and long-term care facilities, hospitals. Everybody needs to go back and evaluate what we've learned over the last 2 years. And that's why we're having this discussion, is trying to bring folks back to so what is our lane as public health? And how do we make sure we're staying in that, as Mike alluded to, that we rewrite and rework our plans to make sure that we capture the things we've learned over the last 2 years. And really get those written into the new version of it. And hopefully will lead us through whatever the next disaster is.
Then we can take those new plans and work with our partners and our emergency managers and train and exercise those plans so that in the future, when the next event happens, whatever that may be, that we're even more prepared. And that's basically the heart of what we do.
And the training will be specific and pointed and worthwhile and not a shotgun approach. It will be be, everybody knows their role, you can train to a point, to a purpose, with an outcome expected, instead of, well, these are the eventualities, everybody will just kind of pick up the load where they stand. It would be a much more effective training regimen and schedule when everybody knows the mesh points, the expected outcomes, obstacles.
James, what are the next steps as far as with helping the program and such itself?
Yeah, so we'll continue to do, the next step really is that reworking of the plan. And like Gardner mentioned, kind of response teams, and I'll just touch base. That's kind of, pretty much down in the details. That's part of our work for our own agency and how we respond in the future, including Amy's team or Maya's team. We're looking internally what we can do better and doing more of those pointed training exercises. And that's an ongoing effort, and we're right in the midst of it, and we've learned a lot over the last few years. And I have complete confidence that we're going to implement really great structures so that we can train and do things on a regular basis so that it's smooth sailing as much as possible. There's always going to be bumps. But again, that's our internal. Externally, yes, with IDHW, there's going to be some hard conversations that need to come up with not only them, but other partners. And we're willing to do that. Ultimately, we want to succeed as a community. We want to make sure that these critical services are there when we need it. That's why we're having these conversations. If we didn't care, we wouldn't worry about it. It just wouldn't happen. But we do care. We do want those services available. The best way we know how is that tried and true way of making sure that it's done on a regular basis. The right people are doing it so that it functions as flawlessly as possible, as many, as few as speed bumps as possible when those time comes. So that being said, yeah, there is going to be maybe some difficult conversations that not everybody wants to hear that, oh, I may have not been doing something right over the last 2 years or 5 years or 10 years or whatever it may be. But sometimes that's a course correction that we need to make. And now is the time to do that. So IDHW will be hearing from us on a more pointed basis on what we're going to expect from them. I think they in turn needs to have conversations with Idaho Office of Emergency Management to make sure they're in communication really tightly together, and then down to the county emergency managers. So again, on that local level through what the county emergency managers see. We're willing to have those conversations with local partners, with county emergency managers and hospitals and EMS agencies and other medical sites, but there needs to be some clear goals defined. Sometimes not just at the local level, but the state level, and that's what our plan is going forward. We ask for your support in that, and then where you can carry that message to, along with your county, emergency managers and whoever you may have conversations with.
I just add my support to that. I think it's a great approach. I think simple, focused on what we do, what we're naturally good at, what the skill sets we really can offer, focus and practice well, so that it's a good, true capability, a true response capability that we can provide the communities. I think it's a great focus. And I'd also add that I think we move forward we have to take care of ourselves. Like it's this region that we can influence. It's not to stick our nose up at the state or anything else. We want to be partners. We want their support. But I think we've learned and from lots of experience that nobody's coming. Nobody's coming. There aren't enough resources to come and help all of our communities in a crisis. It's not there. It's going to be us, and it's going to be the community next door that's going to help us. And I think we just really hone in on that and really practical. Not the plans. We have to check the box for the plans. We're not discounting the plans, but just really practical. This happens, how are we gonna help? This happens, how are we gonna help? And I think if we keep it simple, then it's gonna be effective. Like you said, it's gonna be effective in a crisis.
No, I really appreciate that. I love the practical that they use. That's, in essence, that's what we're trying to strive for. We're trying to be practical in our approach to meet those critical services.
Well, I just want to say I appreciate Dr. Gardner's
Yes.
expertise in this area as we rework, what we've been doing for years and what it looks like going forward. So excited to have you part of this process.
Okay,
There's a few last things if you don't mind. Dr. Gonzalez texted me after she had left the meeting earlier and said she forgot a couple things to report, so I just want to wrap back on that. She said she should have mentioned that the state could go back into pricing standards of care. I haven't been on the last couple daily mock calls, but I know that especially in the Treasure Valley again, resources are very, very tight. And there's talk of getting closer and closer to that again. And this time it's not necessarily because of the impact of COVID on the hospital patient load. It's a lack of staff being out because of COVID. So they don't have enough staff, right, to care for the patient. And then the second thing is, and Dr. Berger mentioned this earlier, that the blood shortage. And I don't know if you're up to speed on the whole thing. She just said that there have been blood shortages across the state in the past few weeks. And the shortages have hit record levels. Red Cross is struggling. COVID has crippled the supply. Hospitals can't order blood. They just get allocations. And that multiple hospitals have gone on divert for various service lines due to lack of blood. For example, one hospital reported going on divert for OB and others postponed surgeries. And that it's a triage system right now. I know the state has been in communication with hospitals and other partners throughout the state of things they might do to implement. I didn't see that email today, but implement strategies to help mitigate the shortages right now.
I received an email from one of my colleagues at St. Luke's earlier this week, and she just said, do you have any notes, anything from past experience on blood shortages and blood that integrated into the crisis standards of care? We talked about a lot of things.
Yeah.
But we didn't talk about blood, and it's different, it's one specific thing. And how do you think of all the different uses for blood in a crisis, and how do you prioritize a delivering mom who hemorrhaged versus a trauma, and it's a significant challenge. So yeah.
Now I can remember, I don't, so I'm gonna say 25, maybe 30 years ago, that there was an order from the National Guard. They called up National Guardsmen to donate blood. And I can't remember what that incident was, but it just strikes me that they had military, National Guard and soldiers donating blood. There's a blood shortage, not to this extent. This is even worse than back then. But I'm trying to remember what that was. Long time ago, before many of you were here, before you were protesting. Yeah.
Two other things related to COVID. 2 days ago, the federal site for free COVID testing went live, and people could go on, I think it's covidtest.gov.
Yes.
covidtest.gov. We've linked that on our website as well, but household can get 4 free rapid tests. You just put in your name, your address, and they will ship out at some point. And you can't, it's only one order per address, just so you know, because people have tried. And then yesterday, I believe it was, there was an announcement that the federal government is also making available higher quality masks for the public for free. I know Mimi shared that on our Facebook page last night, got lots of inquiries. Well, you know, in my area in Chalice, we don't have a Walgreens. Where are we gonna get in here? So we don't have any details on that, but just, that was a resource that was shared at the federal level. And then, two last things. Public health districts are scheduled to have a brief hearing at the JPAC committee. It's going to be on February 14th. At this point, the health districts are not being asked to do any type of presentation like we've done in the past. And Jared Tatro, who is our legislative services analyst, will be giving a brief report on behalf of public health. We may be asked to be on the line virtually to respond to any questions, but that will be February 14th. And then just one last item of note on the governor's budget recommendations that came out on the 7th, right after he gave his State of the State address. His budget zeroed out all funding to the health districts from the Millennium Fund to do FAFSA cessation. And that's concerning to us. In the last, it was maybe 2 years ago, the way that the Millennium Fund allocated the money, they stopped taking grant requests from other organizations that they used to do, and had done an ongoing allocation of funding to the state for Project Filter, as well as the health district for FAFSA cessation services. And I think last year it was nearly $800,000 split between all 7 districts based on formula. But he zeroed that out in his budget recommendation. The Millennium Fund Committee will meet at some point, and they will ultimately make the recommendation to JFAC of what happens with that. So I know health districts are reaching out to their legislators that have members on Millennium Fund Committee and JFAC to talk about that, but we're just following to see what happens there. The one suggestion made is if in fact they're intent on taking it, and from what we've heard, it was to help support Medicaid costs, at least consider giving a 1-year transition period. Don't just chop it off right here 2 months away from now. So, or 6 months. July 1st. So I'll just keep you posted, but that's one more thing.
How hard is that? How detrimental is that going to be to you? I mean, what will that look like?
$100,000-ish reduction to us. With a lot of the funding, we contract with FAFSA cessation providers to do the services in the county. So we would have to terminate that and just not do FAFSA cessation services. That could come from that resource.
Mr. Chairman.
And it is the only real FAFSA cessation program in the state, is what the public health is.
I'm a little bit lost. I need to be educated. What was the original intent for the Millennium Fund? I mean, from my foggy memory, I'm trying to, what was the original intent?
It was the tobacco settlement, like the opioid settlement.
Yes.
And the original intent was for that money to offset the impacts of tobacco addiction.
And cessation.
Yeah.
Oh, wait, we won't have that program anymore because we zeroed out the fund, but there's still money in there to take care.
Yeah, there's still money there. But
Don't be so practical.
I don't like being a politician some days. It just makes no sense.
So what I'm wondering is if this is an issue that we want to, because you can't fight every issue, right? But if this is important enough, we could develop a letter from our health board to send to all representatives from our counties. Would you like us to do that?
I think I would like to wait and see kind of what happens with the Millennium Fund Committee and the backlog that they have around it, and then mobilize after that if you didn't.
Do we have a contact in the governor's office to ask them why did you do that? Somebody's giving him some bad advice.
From what I understand, there's a lot of opposition to it already, right?
I've heard some, but also some support.
So you said that they were gonna take that money and put it towards Medicaid expansion costs?
That's what we've been told.
Seemed like that, I thought that money was designated for this, but maybe not. But is Medicaid expansion, how, do we have any idea what that's extra that's costing that we didn't anticipate? Do you,
I don't have numbers off the top of my head, but I'm sure we can find them.
I don't go a lot extra.
Yeah.
But it seemed like that might be an interesting.
It's a significant amount. I can't remember the number, but it's significant, you know, but the state is sitting on 1.6 billion. So
And that was a comment too, that of all years, this is probably
Yeah.
not one that would be a necessary action. But- And then, just the last thing, I mentioned earlier that I feel like we need to have a meeting next month to wrap up all the loose ends with the House Bill 316 work, and I'd like to propose February 17. That's a Thursday, a month from now. Does that day work for everyone? And I think this could be, 2 hours maximum. We can do it virtually, if necessary for anyone that wants to do it virtually. We'll have the controller's office and we'll use to review and sign off on the policy manual for us. So we'll just have some last minute details to review and discuss.
that works for everyone. Okay, you'll send out a notice.
I know. That's it for today.
Okay, is there anything else from the board came up that need clarification on it or parting thoughts? Sure appreciate all of your attendance here today, and we got a lot of good information today. And one thing I was thinking about is it's so nice to be able to conduct other business now. We got behind on a lot of things last year where everything was so focused on the media. So it's nice to be able to see what's going on in other areas and take care of some of this other work. If there's nothing else, we'll call this meeting to a close. Thanks again, everyone.
Thank you. Thank you.